Good morning. I'm Ann Garst-Taylor, and I am with AIM at Melanoma. I am their Director of Community Engagement, and I want to welcome everyone who's come to be at this symposium with us today. It's always fun to be in a room filled with people. I also want to welcome everyone who is joining us virtually via Facebook and Live and X. Hello to the 100 people who have signed up for this symposium all across the United States. AIM at Melanoma is so happy to be co-hosting this symposium today with Roswell Park Comprehensive Cancer Center. I want to thank Dr. Switzer for leading the charge and for agreeing to be our moderator. These are exciting times. Things are changing rapidly in research and treatment for cancer, and I'm going to be able to tell you a little bit more about AIM at Melanoma and our efforts to support people who are living with melanoma later on. But right now, I want to get to the presentations, as I know you do, and I know that there will be questions. And so I want to explain a little bit about how that's going to work. Everyone who is here in the room with us today, you've been given a packet. I hope you've had an opportunity to look through it. And there is a pad in here for you that serves two purposes. One, of course, so that you can take notes, but also if you have questions for our panelists today, if you'll write them down, we have volunteers in the room who will happily grab those from you. Just raise your hand, and during our 2 Q&A sessions, we'll run them to Dr. Switzer, and he will we'll try to answer as many of those as we can live. For those who are joining us virtually, if you're on Zoom, if you'll look down at the bottom of your screen, you'll see a tab down there that says Q&A. We ask you to put your questions in there. And if you're on X or Facebook, then you can just put your questions in the comment section and we'll transfer them over to Zoom. And with that, I'm going to pass the baton to Dr. Switzer to get started. Thank you.
Good morning, everyone. How's everyone doing? Thanks for coming. Let me get familiarized with our little tools here. All right. So I'd like to thank all of you for coming on a Saturday morning. I'm delighted to share the stage with AIM at Melanoma Foundation and many esteemed colleagues from Roswell Park that are here to share a wealth of knowledge with all of you over the next several hours. I have no disclosures, and I will be starting with a primer for all of our patients. So the origins of melanoma stem from melanocytes, which are normal cells in our body that produce a dark pigment called melanin, so kind of shown here. And these cells are mostly found in the skin, but they can arise in many other areas of your body. They can arise in your eyes, in your ears, in your GI tract, in the mucous membranes of your mouth, of your genital regions, and of your nasal sinus passages. But predominantly, this is something that we see within the skin. And as with many other cancers, these cells can develop genetic mutations where their DNA effectively can be damaged and cause changes that make them cancerous, carcinogenic changes of the DNA. And this gives them the ability to grow and spread and become rather dangerous. In the case of melanoma, the DNA damage is often related to harmful ultraviolet radiation from the sun and tanning bed exposures as well. And here is one of the important pathways in the mutations that we pay attention to in melanoma, and specifically, as I'm sure many of you are familiar with, is a BRAF mutation is rather common that we do see in this process. And then just, in general terms, that's basically these mutations of the melanocytes with the suffix of "oma," just describing a cancer, means that you have a cancer of the melanocyte making a melanoma. When defining the most common cancers diagnosed in men and women throughout the U.S. over the last year or so, melanoma does remain a relatively common diagnosis. Therefore, obviously important for us to continue to pay very close attention to it. But compared to some of the more common cancers, there is certainly a concerning observation that melanoma does tend to be continuing in terms of its diagnosis, whereas we are successfully reducing that diagnosis with some of the other common cancers. And this is concerning, obviously, as melanoma is not the most common cancer that starts from cells of the skin, but certainly most lethal and highly and has the potential to be very highly aggressive. So I presume many of you are familiar with the staging, but just in case anyone isn't, it's important to really understand it because this has major implications on how we treat it and obviously prognosis. So we utilize the TNM classification, which is a pretty standard approach, basically T for tumor, nodal involvement, or metastatic involvement. And so it's obviously much more complex with melanoma than just a simple stage 1, 2, 3, and 4. We have many subtypes, which were last updated in 2017, where we actually added a 4th subtype of stage 3. So obviously this is very complicated and nuanced, but the reason is because there's dramatic changes in the survival, and so basically each one of these have very different aggressive natures to it, and some of them can be much more aggressive than others, and these correlate to chances of survival. So for instance, with patients with a very small melanoma, we would say like one of these T1A here, which would, with no other involvement anywhere, would be falling into a stage 1A category. And those patients, followed over time, have a 98% 10-year survival, meaning that realistically, there is a good chance the majority of these patients have been cured by just the surgery alone. However, melanomas that have more aggressive characteristics with lymph node involvement or much deeper melanomas, and the depth is what's the most important in the staging here. So going down rather than going side to side, which I'm sure will be discussed shortly. So that has major implications in the staging, as we discussed, and that's all comes down to the process that we use here. And another important concept to pay attention to is basically that the biology really is important when it comes to the prognosis. And so as you can see, and maybe it's a bit counterintuitive, that patients who have a stage 3A diagnosis actually appear to have improved chances of survival compared to those with 2B and 2C disease. And this may be counterintuitive at first, but it's effectively based on the biology. So someone with a very angry primary melanoma, even though they may not have any lymph node involvement, falling into one of the later stage 2 categories, do have worse outcomes based on just the biology of that disease in the setting of if they had very minuscule lymph node involvement and maybe a more less aggressive primary melanoma for someone falling into the stage 3A category. Now, one of the encouraging aspects of the curves I just showed is that those data are going back to 1998, which was well before our current therapies like immunotherapy, which many of you are familiar with. And this is rather important because the treatments before the immunotherapies were developed, the survival was rather grim, and this was a long-term observation. And so once the development of immunotherapies came about into the realm of melanoma therapies, there was certainly a dramatic change in survivals, and that's a very important thing to pay attention to, and has now been very well documented. So basically, this table here was showing that there's a very impressive and consistent decrease in the annual percent changes of the survival rates for folks with melanomas. We're for the first time in 4 decades where we can significantly decrease the rates of death starting after these, the major developments of this. So obviously we considered that a huge deal, and obviously celebrate it, and there's been documentaries made on it with relatively solid ratings. So to understand the immunotherapy that I just mentioned, the checkpoint inhibitors, as we call them, it has complex machinery that allows to differentiate between healthy cells and not healthy cells in the body. This is a normal process for your immune system to be conducting. And typically, the immune system has mechanisms that allow it to recognize cells that are not supposed to be there and cause an immune response that can attack them and take care of them. So one way the immune system, and this is one way that the immune system is kept in check, is by expressing certain proteins that prevent the immune system from attacking what we would say your normal cells. So by keeping your immune system in check, the drugs that would block those proteins we refer to as immune checkpoint inhibitors, also known as immunotherapy. And effectively what happens is, so that if the cancer cells are expressing these proteins, then what happens is once you're blocking them with certain agents, which we call the immunotherapies, and many of you are familiar with these specific ones, they allow the immune system to effectively become more activated, recognizing the cancer cells, many other complex mechanisms that I certainly do not have the time to elaborate on, but effectively making the immune system have a more robust response to the cancer that's been developing. Now, obviously, the immunotherapies that we're seeing the responses are for in many patients is certainly exciting. The reduction in mortality is obviously a massive benefit that I will elaborate in more detail shortly. But it's important kind of to, as I'm describing the mechanism of the drugs, is to understand the mechanism of the side effects, which is certainly one of the challenges that we face with these agents. So in broad brushstrokes, the drugs are effectively causing inflammation within the cancer cells. But unfortunately, when the immune system becomes activated by these immunotherapies, you can also trigger the immune system to cause an inflammatory response in part of the body that was not intended. And so the word itis means inflammation. So as you can see here, this is a description of all the various side effects that we observe with these immunotherapies. And you can see the word itis after pretty much any organ. And that's an easy way to wrap your mind around the side effect profile that we can see from these agents. And it's because once again, our normal cells do have these checkpoints as well. And so sometimes there can be this cross communication, and we do observe this. You may or may not have read your notes and that we document in clinic. And if you do, you may see that we're using these grades. And the grades are based off of a standardized approach that's been well established, where we are able to have clearly defined criteria for basically any symptom that you may be developing that we suspect is related to the immunotherapies. So grade 0 means that it's really not interfering much at all. It's almost not existent. Grade 1 means it's kind of burdensome and annoying, but it's not really causing major clinical relevance. Grade 2 is when it is becoming an issue and may actually be causing decrease in your quality of life, and we may need to intervene depending on the organ that's developing the inflammation. And things accelerate very quickly after that. So we consider severe grade 3 and higher. So severe is basically we do need to act on this. We do typically would require hospitalization or some sort of major intervention. For immunotherapy in particular, a gold standard would be steroids. Many of you may have received the steroids for various side effects. And typically it's when we're falling, just classically, it's when we're falling into the stage 3 category where we would pull the trigger to really say that it's time to start higher doses of steroids. And then, as I said, it accelerates quickly. So stage 4 or grade 4 is when you actually have severe enough side effects where you may need to be in the ICU, or it could be considered life-threatening. And grade 5 is it was fatal. The side effect is what was presumed to have been a fatal event. So that's important to wrap your mind around, obviously. So when it comes to the various immunotherapies that we utilize, these are some of the rates that we observe for various side effects. So that once again, as you'll now see in my slides and then future slides as well, grade 3 plus TRAEs is meaning just severe side effects from the immunotherapy. And then we separate out the endocrine toxicities, and what that is side effects from your hormone secreting glands, your endocrine glands. Those have a bit of a different trajectory than some of the other immunotherapy related toxicities. So and they tend to be more chronic, meaning they don't always resolve, whereas many of the other side effects can be resolved, usually with steroids at various doses. So as you can see, the single immunotherapies by themselves tend to have a lower risk of side effects, major side effects, compared to when we have to recommend utilizing combinations of these agents. And it's important to recognize that, as I mentioned before, the immunotherapies are activating your own immune system. So it's not the drug necessarily that's killing the cancer cell, it's your own immune system. And in that same idea, it's also the drugs that are causing inflammation that's making the side effects. So unlike some other drugs where you may get side effects right after starting a treatment, the immunotherapy does tend to take time to really see these side effects become active, because your immune system gets turned on first and then the inflammation comes. So here's a chart of various side effects that we observe traditionally with the immunotherapies. And as you can see, it can take several weeks and sometimes much longer that we will actually see certain side effects develop. So unfortunately, I don't think we're ever completely safely out of the window of side effects, especially while you are on active therapy. And once again, these endocrine hormone secreting gland side effects can really stay predominant for quite a long time and show up much later than most of the others. So just a quick summary here, the low grade adverse events typically actually are a reflection of your immune system becoming activated, some much more so than others. So it is a reflection of your immune system being activated, and when it's been observed, it tends to suggest that there are improved responses and therefore survivals. The more severe ones can be life-threatening, and therefore that's why we keep extremely close eyes on our patients while they're on their therapies. Typically, when the severe side effects occur, the high doses of steroids are required to help get that under control. And obviously, we are working hard to perform additional research that can try and predict patients that may be developing these side effects, as well as better targets to actively focus on the organ that's becoming inflamed. And for the rest of the time I have, I'm going to pivot briefly to just discuss some of the management and the patients that we would consider high risk in the stage 2 and 3 categories. So the reason I'll be discussing this is because usually if you have one of those very early stage melanomas, then effectively the surgery is considered curative. I work in the medical oncology department, so I do not get the luxury to get to see many of these patients. So it's usually when there's much more serious consequences that they would be coming to our clinic. And so this is going to be a quick timeline of how we approach treating that. So basically, back in 2015, so we're looking at basically patients who have a diagnosis of stage 3 and patients with more advanced stage 2. So a timeline of this is 2015, basically ipilimumab was one of the first immunotherapies that we were utilizing in the melanoma space to investigate the survival benefits. And so this particular trial was looking at patients with stage 3A, B, and C disease. Now, this was before the update, so there was no 3D. So that makes a lot of our data that we utilize to show patients a little bit difficult because things obviously are always subject to change when it comes to staging and other aspects of things. But overall, obviously, I think it became very clear that some sort of immunotherapy rather than just observation after surgery has what we call an improvement in recurrence-free survival. And I think it's important that I take a moment to explain what that means. So recurrence-free survival is basically you are still alive and the cancer has not come back. That's kind of a simple way to think about it. And it needs to be both of those things. So truly no recurrence coming back, so recurrence-free survival. And this is different than some of the graphs you'll see later where we discuss overall survival. And the reason why in what I'm talking about right now, I'm not talking about overall survival, is that a lot of folks who have their melanoma removed surgically may be cured. So it's very difficult to statistically prove that there's going to be a true overall survival benefit. But what is important and what's more tangibly measurable is whether or not the cancer comes back within the time frame that we're doing these trials. So I know I won't have much time to go over all of the details of this, so it's hard for me to give you all the exact numbers, but basically these studies have been done long ago, and therefore we have long-term follow-up that is observing the reduction in the risk of the cancers coming back with patients who did undergo treatment after the surgeries versus those who did not. Now this one was one of the more historical ones because one thing we've discovered is that ipilimumab by itself realistically does not have nearly as effective of a response as the checkpoints that target what we call PD-1, which is a different checkpoint that I'll show in a second. But also high doses of ipilimumab by itself really can be extremely toxic. So it really has fallen out of favor. So in 2017, then there was a trial that was done that looked at Ipi, as I just mentioned, versus Nivo. So they really compared the two. And this is one of the trials that truly set nivolumab apart from IPI and the PD-1 agents. And so many of you have probably seen the word IPI, been treated with IPI, that sort of thing. And this is one of the many trials to show why we don't typically use IPI by itself. It's usually something that you would see in a combination. Whereas you will see things like nivolumab and pembrolizumab utilized commonly by itself. And so basically the endpoint of these studies with these patients were recurrence-free survival going out to 4 years. And once again, utilizing the Nivo was significantly better than the IPI. On to 2018, this was patients with stage 3A, B, and C that had their melanoma removed. This one was looking at placebo rather than any additional treatment as compared to this one. So this was utilizing pembrolizumab versus just observation after surgery. And obviously there was once again, appreciable difference that treatment after surgery for these folks it was important in terms of reducing the risk of the cancer coming back. These lines may have even been further spaced out, meaning even more impressive. However, the trial was made in such a way because of the fact that it was a placebo that there was crossover allowed, meaning that if the cancer did come back, you were allowed to start on therapy. And running out of time, so I will go a little bit quicker for the rest of these. So I mentioned the BRAF mutation earlier. It's a mutation that is commonly observed in many patients with melanoma, and if they have that mutation, they are eligible for what we call targeted therapy, which is different than immunotherapy. It's a pill that truly targets a specific mutation. And so for patients who have a melanoma removed in the stage 3 categories, who have the BRAF mutation positivity, this was studied in a trial where they also observed that utilizing these drugs significantly reduced the risk of the cancer coming back compared to a placebo, meaning just observation after the surgery. Sorry. So I will cruise through the rest. So then the patients with the high-risk stage 2 patients with high-risk stage 2, obviously there was not, everything I just discussed was in the stage 3 realm. So later on, 2021 is when we started to look at the patients who have a high-risk stage 2 diagnosis as well. And so these are the data that came out, and obviously it was a bit longer because they first focused on the more high risk in terms of stage 3, and then obviously they moved their focus to high-risk stage 2. So this came later. And once again, the recurrence-free survival was appreciable through the utilization of anti-PD-1 checkpoint inhibitors, meaning pembrolizumab, and as well as nivolumab. And this is the chart that showed that in Checkmate 76K. It's important to recognize that the side effects of these drugs were significant, were notable, and relatively high in some of the trials more than others. Between 10 to 15% in many of them. And then, as I mentioned before, some of you have heard or been treated with IPI and Nivo together, ipilimumab and nivolumab together. This was studied in the stage 3 population, and really there was after surgery, getting things removed, and there was really not much of an appreciable difference in that recurrence-free survival. So this is one of the main trials that ultimately did guide us to not recommend the combination in the setting of having your melanoma removed in a stage 3 category. So quick summary of what I just described there. Stage 1, early stage melanomas can be considered curative with surgery alone, which will be discussed shortly. Stage 2, B, and C is considered higher risk, and there is an appropriate discussion to be had about the potential benefits of having therapy after surgery, which is that the term adjuvant means therapy after surgery. And in the stage 3 categories, what's considered the highest risk would be B, C, and D, and it's important to have conversations about the benefits of treatment after surgery for that diagnosis. Obviously, the discussion is important because the side effects are known. And then very briefly is that there is new data that has come out in what we call neoadjuvant, which is when we treat with immunotherapy before surgery. And this has been an exciting development over the past few years. And it kind of goes with the science that I discussed, is that if the immunotherapy is allowing your own immune system to recognize the cancer cells, then if we're cutting out the cancer cells first and then treating you, your immune system may not be able to recognize the cancer as well as if we left the cancer in the body. And so this is where the neoadjuvant approach kind of makes sense scientifically. And as you can see, there's increased cells that are able to kind of recognize the cancer cells in the neoadjuvant arms. And so do not have time to explain the neoadjuvant approach in much detail, but I will just say that there's very encouraging findings where if we are treating our patients with clinically detected nodal involvement, and lymph nodes are involved, we confirmed there's melanoma, and it's large enough where we feel as though we can clinically detect it, then patients are basically being offered an individualized treatment approach where you have 2 doses of combination immunotherapy. Then you have the node removed, and then based on your own personal response, determines your next steps in terms of treatment and has rather significant implications in the outcomes, which I can discuss in person if anyone wants to talk more later. So my conclusions, that melanoma exhibits many aggressive features compared to more common skin cancers, which may be fatal. Melanoma at early diagnoses can be cured with surgery, and therefore dedicated efforts in early detection and routine UV protection is vital. High-risk melanoma, systemic therapy discussions are appropriate after surgery, but should be discussed, with a clinician who understands the risks and benefits to truly help you understand what kind of benefits you're achieving and the risks that you would have with those therapies. And immunotherapy has dramatically improved the outcomes for patients with melanoma, but carries a risk of severe and/or chronic side effects. And research is ongoing to improve the success rates of all of these treatments, and particularly in patients who may not be responding well to the therapies that we do have available to us, as well as just truly are not tolerating the therapies that we have offering. And we are working very hard on that here, and you'll probably hear more about that shortly. And that is all I have. I'm sorry that I went 5 minutes over. And just to keep the time moving, we're, once again, any questions that you do have, feel free to write them down. We'll have folks that are able to grab them.
Thank you very much, Dr. Switzer, for giving that introductory presentation, and thanks for AMET Melanoma for pulling the symposium together. I'm George Perg. I'm a dermatologist here at Roswell Park, and our goal here in dermatology is actually to keep you out of the hands of the oncologist. So I'm actually going to talk about what I say is molar monster, diagnosing melanoma, detecting melanoma early, and predictors of risk. In my talk, first I'll talk about incidence, melanoma in numbers, then we'll briefly talk also about the origin of melanoma monocytes. We'll talk about who's at risk for developing melanoma, the major risk factors, and then we'll discuss subtypes of melanoma because that's very important to know in order to be able to recognize disease. Then we'll talk briefly about benign, pigmented, and non-pigmented skin lesions because obviously melanoma doesn't come on perfectly normal-looking skin, and therefore it's important to understand the other lesions that we need to differentiate them from. And then we'll talk about the morphological features that enable us to diagnose melanoma, and then we'll talk about how we actually diagnose melanoma out of the lesions that look suspicious. First, let's talk about incidence. As Dr. Switzer also alluded to it, melanoma incidence has been rising very rapidly in the last decades. The silver lining, however, is that luckily in the past few years, we've at least seen a slight reduction in melanoma mortality rates. Nevertheless, currently we diagnose annually over 100,000 invasive melanoma cases, and melanoma results in over 8,000 deaths annually. And because of this, currently the lifetime risk of developing melanoma is over 2% in the US population. The median age of diagnosis is 59. And unfortunately, although melanoma is more common in older individuals, it is the most common cancer in young adults between the age of 25 and 29. Because of the very high incidence, we currently have almost 1.5 million people with a history of invasive melanoma. And it's important to realize that this really only captures invasive melanoma. Because when it comes to non-invasive melanoma, that's not even captured in these numbers. Melanoma in situ, we also diagnose approximately 100,000 cases of each and every year. So if you added all that, we actually have a lot more patients who have been affected by melanoma. Again, I already mentioned that the only good thing is that we actually capture quite a few of these melanoma early, and because we capture them early, luckily the mortality rate has been decreasing, and also it has been decreasing because there's better therapeutic options. As early diagnosis is key, next we'll talk about the origin of melanoma, and then we'll talk about the features of melanoma to essentially enable everyone to possibly diagnose melanoma early and earlier. Melanoma originates from melanocytes. Melanocytes are the cell type that produce pigment in our skin. And these melanocytes are responsible for all the shades of color that we see in our non-sun exposed skin. Their normal function is to reduce sun damage to our skin by producing more pigment. But in that process, they can also themselves be damaged, and then because of accumulating damage can undergo uncontrolled growth, resulting in the formation of melanoma. As the damage is crucial, we very well understand that melanoma is majorly triggered by prior ultraviolet light damage and accumulating mutations in pigment cells, similar to other skin cancers, but obviously other skin cancers are triggered by accumulating mutations in other cell types within our skin. Because of the importance of UV exposure, obviously UV exposure is also a very well-known and important risk factor in melanoma. Sun exposure and indoor tanning are both understood to be important risk factors, but it's also important to realize that it's not only the amount of UV exposure, it's also the mode of UV exposure that matters. And we clearly know that bad blistering early life sunburns are a very important factor in, for example, superficial spreading melanoma, the most common subtype of melanoma. We also understand that it's not only sun exposure, but also some personal characteristics that are important in melanoma risk. Large number of nevi, a large number of atypical nevi, a large congenital nevi also put people at increased risk. Very fair skin, kind of red hair, blue eyes, freckled skin, inability to tan puts people at increased risk also. A family history of melanoma, and also family history and personal history of other skin cancers can put people at also increased risk. Melanoma risk increases with age, but again, do not forget that unfortunately melanoma does not spare those of us who are younger. Male gender is an important risk factor. Men are almost twice as likely to get melanoma than women, but again, there are different sort of age characteristics to this. And we also understand that a weakened immune system can put people at an increased risk of developing melanoma also. But I want people to understand that not everyone has obvious risk factors who develops melanoma. Some melanomas come in areas that are hidden, that are not sun exposed, that are mucosal sites. Some melanomas can come in the depth of the eye, and some melanomas can form actually without even a prior skin lesion being present. Some melanomas may pop up in the lymph nodes or even at distant sites. So again, what I'm going to talk about is obviously going to be mostly cutaneous melanoma and how you can recognize it, but we should not forget that not all melanomas show up in these sites. And even if someone does a superb job with this, we can't unfortunately capture all melanomas early enough. Again, in order to understand melanomas and to be able to capture them early enough, I think we have to talk also about subtypes. All of the melanomas come from pigment cells, but although they come from pigment cells, they can look quite different based on the subtype. These are the major subtypes. First, we'll talk about superficial spreading melanoma, then nodular melanoma, after that acral lentiginous melanoma, and then lentigo malignant melanoma. Superficial spreading melanoma is the most common subtype, responsible for approximately 70% of the cases. And it usually is the melanoma that presents earlier in life. It can arise either as a brand new lesion on the skin, as we call it de novo, or it can also show up in pre-existing moles. It's important to realize that this is the subtype that's, again, very common, but is also often driven by intermittent large amount of sun exposure, so it's actually fairly common in areas of the skin where people burn, but don't necessarily get most sun. For example, the back, middle of the back, or the calves in women. Superficial spreading melanoma after an initial phase of growth goes through a slow, usual radial growth phase. Then the border regularly increases, areas of regression appear, after which, again, months to years later, usually the vertical growth phase starts taking place where the melanoma starts spreading deeper. It's important because usually as melanoma starts spreading deeper is when you can start seeing the risk of metastasis increasing, and therefore in superficial spreading melanoma, often we have more time to catch it early than in some other types of melanoma. These are also the melanomas that many of the features that you may have heard of and that we'll talk about later can be recognized easily on: the asymmetry, the border irregularity, the color variation, the increased diameter, and the evolution. Next, we'll talk about nodular melanoma. Nodular melanoma is the second most common subtype. And it is responsible for approximately 15 to 30% of cases. It is more common later in life. This lacks that radial long growth phase. Therefore, often we don't have the luxury of catching it as early unless someone is paying very close attention to their skin, because this is one that usually will start with rapid vertical growth and therefore is often recognized later when it's thicker and then there's poorer prognosis. This shows again a male predominance, and it is very frequent on the trunk, head, and neck. And this is more common in the highly sunburned areas of the skin, and it's not as much driven by intermittent sun exposure as the superficial spreading melanoma subtype. These are some of the images of nodular melanomas. It's important to recognize that sometimes in nodular melanomas, you see the underlying sort of precursor lesions. Occasionally, you don't see anything. You just see sort of an ulcerated tumor. Sometimes they are large. Occasionally, they are much smaller. And sometimes they are actually harder to differentiate from just atypical nevi. And occasionally, they can also lack pigment or only have very subtle pigmentation, or may even only have a bluish hue to them, as opposed to sort of commonly people thinking of melanoma as a brown or black lesion. Next, we'll talk about acrolentigenous melanoma. This is a subtype that's very important to know about because we should not forget that, again, not all melanomas come in sun-exposed area of the skin. Acrolentigenous melanoma comes on acral surfaces, so the palms and the soles. We'll see a couple of images later on. Usually it will present around the nail unit or in areas of possible trauma on the palms or on the soles. It usually comes later in life, but can come also earlier. And this has a similar incidence across all pigment type groups. And because of this, this is actually the predominant melanoma in darker skinned people. These are some images. You'll see here an acrolentigenous melanoma affecting the great toe, causing discoloration in the toe. Often these will show up as initially just color change under the nail, and later on can spread to the surrounding nail fold. And occasionally, again, it can also show up on the plantar or palmar surfaces as a large growing black to brown patch. Occasionally, they can ulcerate. Next, the last sort of major melanoma subtype that I wanted to discuss is lentigo malignant melanoma, or malignant freckle. The lentigo malignant melanoma is one of the subtypes that goes through usually a very slow radial growth. It often happens and often comes in highly sun-damaged areas of the skin. The trick with this melanoma subtype is that often as it grows fairly slowly, people may remember something having been there for a long time. And this is where I think now cell phone photography can help people tremendously, because if people look at something that looks odd, they are unsure of sort of what may have happened in that area, and they go back to photos that they may have on their cell phones from 5-10 years ago, and they establish that subtle, insidious, slow growth, again, that may alert them to a possible lentigo malignant melanoma. Or lentigo maligna. It starts again with a radial growth phase, then it's a malignant freckle only the top of the skin, and then later, often after a decade, sometimes even 2 decades, it will go through a conversion into invasive growth and will form a lentigo maligna melanoma at that time. This represents approximately 4 to 15% of melanomas, and again, this usually happens in highly sun-damaged areas of the skin. These are some of the images. And again, initially it will spread laterally and will grow radially and will cause pigmentary change in the skin. And then later on within these areas, bumps can appear that can sometimes be black, sometimes they can also have bluish features. Occasionally they can look pink even. That will signal that the melanoma has gone beyond just being in the top of the skin and has been able to spread underneath. As I mentioned previously, early diagnosis is key, and early diagnosis is key because the earlier we catch melanoma and the thinner it is, the less likely that it will spread, and the easier it is to keep you out of the hands of oncologists and to just take care of the melanoma with surgical means. But in order to understand early diagnosis, we need to be able to differentiate pigmented lesions and problem pigmented lesions from benign lesions on the skin. Because don't forget that unfortunately the Photoshop fake images in the media are not reality. Our skin is littered with normal skin lesions, and we really need to identify problem spots against this background. We have numerous benign non-melanocytic lesions that can look pigmented, like seborrheic keratosis or stockokeratosis. We have red spots in our skin, like cherry angiomata. We can see purple spots, which can be oftentimes just purpura on our skin, or we can see scar-like lesions like dermatofibromata that again can resemble some melanoma subtypes. Then we need to differentiate problem spots from these lesions. And obviously we also even have quote-unquote moles, so melanocytic lesions on our skin that are completely benign, which are just local proliferations of pigment cells, which are again common, benign, which can be congenital nevi that can be present from very early on or even from the time of birth, can be small or large. Occasionally they can even be speckled. They can also be acquired. Sometimes they are dark in color, occasionally they are pink. Sometimes they can have multiple features, a bump in the center and sort of flat areas around. And occasionally they can even have some pigment variability within them. Sometimes they can even have very striking signature on the skin when multiple similar appearing but very striking appearing nevi can present in individuals. And occasionally they can even present with features that are reminiscent of some early melanomas and can even have histological features of atypia. But it's important to realize that the vast majority of these moles, of these pigmented lesions on our skin, will not turn into problem spots. And these are essentially benign. When it comes to completely benign nevi that have no features of histological atypia, the chance that they convert into melanoma is somewhere around 1 in a quarter million. When it comes to atypical nevi, sort of run-of-the-mill atypical nevi, that chance is only 1 in 40,000. So that's the reason why we actually consider these benign, and our goal is to differentiate melanomas and sort of very early melanomas from these pigmented lesions that are, again, completely harmless. What enables us to differentiate them? What are these morphological features? I think you probably all heard of the ABCDE. These are truly time-tested features of recognizing problem pigmented lesions. The ABCD criteria were published in 1985. E was added in 2004. And again, they all withstood the test of time. When we talk about the ABCD criteria, we talk about asymmetry. So one half of the mole looks different than the other half. Border regularity, instead of a nice smooth transition over into the surrounding skin with sharp edges, there's fuzziness. There are almost like legs going into the surrounding areas. Then color variability and color variation, where you see multiple shades of gray, blue, black, tan, pink in the lesions, again, raising the concern that the lesion may be actually an early problem spot. Diameter, often problem spots tend to be larger, and evolution. Obviously, something that's pigmented and evolving is much more likely to be a concerning spot than something that has been staying put and completely unchanged for decades. One other thing that I love to add to these is which we often forget about is the ugly duckling sign, or as I often tell my patients, and some of you may have heard, the F feature, so that makes it A, B, C, D, E, F, funny or funky. Ugly duckling sign means that usually melanomas are going to be singular on someone's skin. So when you see something that's really odd, that stands out of the crowd, that looks very, very different than anything else, obviously that is probably the problem spot that we have to focus on. And this, I think, is a great cartoon about the ugly duckling sign. But do not forget that these features do not describe all problem spots, because some of the melanomas are going to be pink and maybe fully pink, or may only have minimal grayish tones to them. Therefore, in order to really capture all problem spots, we actually often use additional features that we take from sort of the non-melanoma skin cancer handbook, which are also important anyhow, because if someone has a history of melanoma or is at high risk of melanoma, they often will be also at a much higher risk of developing non-melanoma skin cancers. And these features are growing pink papules. If someone has something that's slowly growing pink, but progressing, that can actually also be sometimes a sign of skin cancer. The majority of these are not going to be melanomas, but sometimes melanomas can also show up like this. Sores that do not heal can also signal possible skin cancers. Skin areas that bleed frequently after little trauma can also be a sign of underlying skin cancer, and spontaneously appearing growing scars can occasionally also signal cancerous lesions in the skin. How do we catch these? One of the things is that it's not us only who will be catching these. I really think that self-skin check in individuals who are at very high risk is absolutely crucial and is of paramount importance. But one thing that you also need to realize that self-skin check should only be self. I always tell everyone that yes, these brochures that show you how to use 2 mirrors are great, but when you imagine how easy it is to look at your own back with 2 mirrors, you will soon realize that best is to actually ask the help of a loved one to look at your back, look at the back of the scalp, and help actually do self-skin check with company in order to make sure that you can capture possible problem lesions earlier. Once a possible problem lesion is identified, obviously we still need to diagnose it. For that, we recommend that you go to a professional. It's best to go to someone who uses dermoscopy, who actually looks at these lesions under magnification with polarized and non-polarized light to be able to identify other features that with the naked eye none of us can see. I'll tell you, I feel completely lost without my dermatoscope. I travel with it because if anyone stops me and asks me about something, I feel that I can't really comment on the truly important features. And after we see something that truly looks concerning, even on dermoscopy, obviously we still need to prove that. And how do we prove it? We do a biopsy. We usually will prefer complete removal of the lesions with excisional or complete shape biopsies, but occasionally when the lesion is very large, we'll still opt to do incisional or punch biopsies of larger areas. And obviously after that, we need the pathologists to help us because they are the ones who ultimately will help us diagnose these lesions, and you'll hear more about that in the next talk. So in summary, I talked about incidence, recognize that unfortunately melanoma incidence has been rapidly rising, but do understand also that there's a silver lining because mortality rates luckily have been dropping. Also understand that melanomas come from pigment cells, but remember that not all melanomas, although they come from pigment cells and they are based on mutated pigment cells, not all melanomas will be dark and pigmented. Do know that higher level of prior sun exposure, lack of prior sun protection, bad early life sunburns, fairer skin puts people at increased risk. Also remember some of the subtypes, and I want to highlight also that some of the melanomas come in intermittently sun-exposed, previously badly sunburned areas and not the most sun-exposed areas of the skin. And also remember that occasionally melanomas can come up in areas that have not really seen sunlight previously at all. Remember also that there are many pigmented skin lesions that you need to differentiate problem lesions from. Remember the A, B, C, D, E on morphology, and don't forget the ugly duckling sign or funny and funky lesions. And also remember that after you recognize something, it's important to talk to a professional and actually establish a diagnosis early so that it can be treated and curatively removed with surgery so that you don't have to see our oncology colleagues. With that, I wanted to thank you all for the attention, and I wanted to actually have Dr. Andia continue with the talk about the sort of the point of view of a pathologist.
Thank you very much. Would it be possible to get rid of the top? Yeah, that's better. Thank you so much. I'm honored to be able to present in front of you. My name is Doro India. I'm a pathologist that specializes in the diagnosis of skin diseases and skin tumors. That's why it's called dermatopathology. And I'm going to try to shed some light on a more hidden part of pathology of melanoma treatment, which is the pathologic examination. So today's goals are going to be to introduce the field of pathology, outline the primary ways in which pathology contributes to the care of melanoma patient, and also discuss the role of second opinion in pathology. So what is pathology? It's a field of medicine that uses laboratory methods to study and diagnose disease. And pathologists that work here are physicians with specialized training that, among other things, are responsible for guiding medical treatment by studying tissue samples and also blood. And pathologists do this by using a variety of laboratory methods that help diagnose melanoma and guide the treatment. This is our faculty, pathology faculty at Roswell Park. And this is the team that specializes in melanoma diagnosis. And this is Dr. Alicia Goldenberg, Dr. Paul Bogner, and myself. I want to acknowledge Dr. Bogner for sharing some of the slides for this presentation. So what is the role of pathology in melanoma diagnosis and treatment? The first and probably one of the more important roles in this diagnosis, as Dr. Para said, it's important to have a pathology exam in order to be able to differentiate between nevus and melanoma, so between benign and malignant. And you've seen images of these pigmented lesions of the skin, and you may have a suspicion clinically that some of this might be melanoma, but often, almost always, the final diagnosis is established by pathology, either benign or malignant. So how do you do this? So what happens, a tissue sample is taken at the time of the examination. It's placed into a container filled with a substance that helps preserve the tissue, which is a fixative, sent to our department of pathology, and in a few days you have a pathology report. So what we're going to do is try to look behind the curtain and see exactly what happens actually in the pathology department to diagnose these lesions. So the piece of tissue is placed in one of these plastic cassettes, and that's put in that tissue processor that you can see on the left here. Let's see if I can, this one. And what happens here, the tissue is infused with paraffin to make it harder. So instead of being soft, it's going to be harder, and you'll see why, because you need to cut it. Taken out of the tissue processor, and we use a mold to actually embed that tissue into paraffin. So you can see here, what the technician is doing is putting into this metal mold the tissue, and then from here you can pour liquid paraffin into this. And ends up that after the paraffin solidifies, you get a block of paraffin that contains the tissue of interest. The next step is to actually section it. So you use this device called a microtome. It's kind of similar to a deli slicer, but much, much more precise. And you cut these sections that are 4 or 5 microns thick. To give you an idea how the thickness of this, like the spider net, is about 3 to 8 microns. So it's about the same thickness, and it's much, much thinner than a paper sheet. Those sections are then floated onto a water bath, and you can come, this is a glass slide, you can come underneath and pick them on the slide, and you end up with these glass slides that contain the tissue, very, very thin sections of the tissue. Now, these are transparent, so you can't see anything of them, so you need to color them. So we use a stainer. It's pretty much the same as you'd stain, or you dye your clothes, for example. So you put the tissue through various stains. The ones that we use are eosin, which is pink, and hematoxylin, which is purple. So it's going to be a pink-purple color. And then you end up with these slides that are now colored, so you can see what's going on. So the next is one of the most important parts, which is a microscopic examination. So this is performed by a pathologist, who again is a physician with additional training in recognizing different patterns that help diagnose benign or malignant lesions. And he uses a microscope, so you can see the slide displays here, and this will magnify the image and you can see it on these eyepieces. And then the renders a pathology diagnosis. So that's what one of these pathologists will see under the microscope. This is a picture of the skin magnified 20 times. And you can see up top here, this is the surface, which is the epidermis. That's what you can touch on your skin. This pink thing would be like the dermis, and underneath this is fat, is the subcutaneous tissue. You can see shades of pink and purple because of this hematoxin and eosin. You can go even higher magnification. This is now 400 times. So now you can see individual cells. This is the surface epidermis, the surface of your skin. This is called stratum corneum. That's why the skin is impermeable. Water doesn't penetrate. And you can see the purple round structures are the nuclei, which contain all the DNA that's needed for cell function and replication. And then the pink stuff around this is the cytoplasm. This is one cell. These are all sort of skin cells, but here and there you can see these are the melanocytes. These are the normal melanocytes we've been discussing. These are, look, uniform and small. These are not malignant. You have the organism, as was discussed before, to protect you from UV exposure from sun. Now, this is how some of these lesions might look like. On the left, you see a benign lesion, which is a nevus. On the right, you see a melanoma. It's a special type of melanoma called nevoid. It's called nevoid because it looks like a nevus. So this illustrates why it is important to look under high magnification. And you can see there are some differences in the density of cells. All these little purple dots are melanocytes. Now there's many, many more melanocytes. And you recognize that there's, you can look at certain patterns and differentiate benign from malignant. These are some of the features we look at the microscope to differentiate a benign lesion versus a malignant lesion. We're not going to get into the details. This is highly specialized, but just to give you an idea of the skill that's needed to do that. This is not a type of melanoma. This is our Dr. Bogner, who does that all the time. So you can see here, these are the melanocytes in the epidermis. So you can see how many more there are here. So you can look at certain patterns and say that this is malignant, and specialized physicians can diagnose that. The second role is to classify a type of melanoma. So melanomas, it's considered to be not even one disease, but several related diseases. And same as you see here, the apples, they're all apples, but some are red, some are, yellowish. There's different types of melanoma you can recognize under the microscope. And it's been discussed, various types, and I'm not going to go into the details, but just show you like an example. This is a lentigo maligna and a superficial spreading melanoma. And they're both melanoma. You can appreciate these dark dots are the nuclei, or the purple dots of the melanocytes. Remember the normal skin, there are only like 2 that you could see. There's like many, many here, and same in this area. So they're both melanoma, but the way the melanocytes are arranged is different. So to the trained eye, you can differentiate that one is lentigo maligna, one is superficial spreading melanoma. The next role is establishing the stage, or helping establish the stage of the melanoma. So what is staging? It's been discussed before. It's a measure of the extent of cancer at a given point in time, usually at the time of diagnosis. And there's 2 components. There's a clinical staging that's done using the clinical parameters. So you can look how far the disease has spread. And there's also a pathologic staging where you need to use a microscope to establish the stage. As we've discussed, staging provides prognostic information and affects treatment planning. So it's important to stage the patients correctly. We discussed that we're using this TNM staging, tumor, stage, lymph node, which is the spread, and then this distant metastasis. And the tumor stage, this is one that you need pathology for it. So this is an example of a melanoma, a nodular melanoma. And you can see this whole circle encompasses the melanoma. You can see a little bit here of the surface epidermis, and this is a large nodule. You can imagine this was be a nodule on your skin, and then there's a bit of epidermis here. So one of the important parameters is measuring the depth, and we do this under the microscope using a specialized eyepiece that can actually measure with it. So In this case, it's 8 millimeters. And you also assess if there is ulceration or not. So ulceration means that the epidermis is gone from the surface. So you can see this area. You can see epidermis here, and then it starts to disappear. So this area is ulcerated. That will mean pathology tumor stage 4B. And you can use these other classifications for T from in situ to T4 based on the depth and the presence or absence of ulceration. You need a microscope to do this. Next is the end stage. You look for metastatic tumor cells, and this could be clinical. If the metastases are big and bulky, you can see them on imaging or even palpate them. But sometimes they're very, very small. This is a histologic image of a lymph node now. You can see this round structure. The purple dots are all lymphocytes, so it's hard to see much. But then if you look under the microscope in a certain area like here, you can detect there's some pigment in these cells. It's still hard to tell. I mean, I can see that maybe this one looks a bit atypical, but I wouldn't necessarily be able to tell if that's a melanocyte or some other cell that has pigment. Luckily, we have special stains. So these are particular stains, different than hematoxin and eosin, that stains only melanocytes. So you can see now all the cells that are basically bluish are not stained, and you can see this large one here has a brown cytoplasm. So this is a melanocyte. You can see the nucleus is very large compared to the surrounding one. This is a malignant melanocyte. So this is a positive lymph node, but you need a microscope to detect that. There's other parameters that you provide. These are not used for staging, but are used, they have some correlation with prognosis, such as the mitotic rate. Presence of microsatellites actually is used in staging, so I take that back. Lymphovesical invasion, neurotropism, and so on. So there's additional parameters that they are put in a pathology report. And then the last role is to be a guidance of therapy. Can either predict the therapy or verify the response to therapy. To understand how you predict the therapy, we'll talk a little bit about how do we understand the melanomas arise and progress. So we think there is a precursor cell, which could be a melanocyte, one of those normal melanocytes you've seen. Your cells in your body, by chance, will undergo mutations. So it happens at a relatively high rate in all of us. Most of those mutations don't produce anything. The cell will basically die or not proliferate, but every now and then there is one mutation that activates and makes the cell proliferate. So this is a hit, a genetic alteration, and will produce multiplications of these cells that all contains this hit. And this usually creates a nevus. So nevi have this one, nevi will have one of these, nevi can have BRAF mutation. What happens by chance, one of these cells can acquire another mutation, and that will produce a second wave of proliferation, creating like some sort of intermediate melanostic tumors, not quite melanoma, but in its way. And then there's additional alteration that will produce melanoma, okay? You can have this process going very fast. You don't necessarily have to see a nevus like it was discussed before. Only about 20–40% are associated with a nevus. Or it can arise from a nevus without an intermediate tumor. So you can see the nevus associated. It's kind of rare to see all these three. But what's important to sort of realize is that these hits, these events, can be used to treat melanoma. So if you have a therapy that inhibits one of these, it will stop this sort of progression. It will stop the functioning of the melanoma cell. And the most important ones are the early ones. Like, for example, this first hit is one that drives the entire melanoma. So if you stop that from the melanoma cell, it potentially stops the melanoma from growing. And this is an outline of us. This is one single cell. This is the outside, the membrane. This is the nucleus. And this is one of the pathways that are normal in the cells that transmit a signal from the surface and make the cell proliferate. That happens all the time in normal cells. So you have these molecules that activate like a domino. So this gets activated by the molecule on top, and this term activates the molecule on the bottom, and so on until it gets to the nucleus. And you recognize some of these players here, like BRAF. So for example, let's say you have an alteration of BRAF that makes this molecule active all the time. It doesn't require an input from upstream. That will go to the nucleus and activate this entire cascade and make the cell proliferate. That's how, nevi appear, for example. That's why melanoma partly proliferate. So now if you have a drug that stops that in these melanocytes, then you're going to stop proliferation. So that's very important to be able to know that the tumor has these events. So, luckily pathology can study the tissue, so you can look at the tissue and identify this broken system, these events, and then you can decide you can treat one of those. And we do this by looking at DNA and RNA. So DNA is this double helix that, as you know, stores all the information for the cell to function and to proliferate. And RNA is produced from the DNA, and from here you produce proteins that activate, that functions as machinery that make the cell work. And we look at there's a process technology called next generation sequencing. I'm not going to go into details, but these are some of the machines we use that will tell you exactly what's broken in the cell. The other sort of arm of treatment pathology can help is verifying the effects of the treatment. And the most simple one is checking if the margins are free. So imagine this is a melanoma, and you do an excision around the melanoma. So you want to make sure that everything is out, but you don't actually, sometimes you don't see the extent of the melanoma with your naked eye. So the idea would be to be able to look at the normal tissue around the melanoma and make sure that's all normal tissue. You don't have melanoma touching the margin. And we do this by looking at, this is a section of that melanoma. This is the melanoma right here. This is the surface epidermis, and this is where the excision was made. We often ink it with a color so we can tell this is black. So you don't want to have melanoma touching here because the rest of the tissue is left in the body. So then if you look at that, you can see, well, there are atypical cells. These are malignant melanocytes that touch the margin. So this margin is positive. That's going to be conveyed, so you need a larger excision here. There's going to be a second procedure to treat the disease. The second modality in which pathology can have an impact is looking at the effect of therapy. So this is a melanoma patient treated with an immunotherapy agent, which is pembrolizumab in this case. And you can see this used to be all melanoma, and now it's all necrotic. So this is melanoma that's dead, basically. So you can assess and say, okay, this patient had complete response, almost complete response, which is a good thing. But you need pathology to assess this. Otherwise, this will kind of look also like a mass forming if you look at imaging studies. One important portion that's not necessarily immediate important for treatment of patients, but for the future, is the ability of pathology to manage tissue for research and future testing. So as probably most of you know, if you're asked to give a consent, the tissue that's procured for the melanoma, which is going to be procured anyway because the tumor needs to be taken out, not all the tissue is used for diagnosis. So what's left can be preserved and used for future studies, future clinical trials. And usually in the pathology department, there is the infrastructure that gives them the ability to store this tissue so that it can be used in the future for various other research and to basically advance the science. One important thing aspect of pathology is the ability to give second opinions. All of these are, the slides can be preserved indefinitely, so other people can look at them. And you ask, why would you need that? Well, the overwhelming majority of lesions we can diagnose by histology. So you can see at this whiter end, it's a nevus. At this more black one is melanoma. But life is not black and white. There's different shades of gray. So, less gray we think is a nevus, more black we think is melanoma. But what about the in-between? There's an in-between. And We want this to be as little as possible, but these are going to be the lesions that are borderline, and maybe I've heard this term, or very, very challenging to differentiate if it's a nevus or if it's melanoma. And in the best of worlds, these ones, we want to know what to do with them, and maybe, classify some that probably these are benign, some probably malignant, but we cannot use conventional histology to do that for this small. So this is, sorry, this is where you can either have a second opinion. So there's people with a lot of expertise. Usually the dermatopathology board has certification, like our team here, that you look at these lesions all the time. So you're better in differentiating benign from malignant. Most of the time they work in a team, so you can have multiple inputs, and obviously, more people, usually generate a better, better diagnosis than one person. But just know that differences in opinion in these lesions are not rare. So when that happens, most of the time, we try to do additional testing. So for a subset of this lesion, you need additional testing, usually looking at molecular events. So that's why I have like this DNA here. Usually I have molecular tests that look at the DNA. And why is that? So if you step back a little bit, melanoma is a malignant disease and has an unstable genetic material, which accumulates a lot of abnormal findings, whereas nevi shouldn't have that degree of abnormality. So if you look at the DNA, if you have some of these tests, fluorescence in situ hybridization, comparative genomic hybridization, they look at differences in the, you normally have 2 copies of each gene. So you have more than 2 copies or less than 2 copies, that's abnormal. You can also look at mutations of specific genes that can be associated, like third promoter is associated with melanoma. So just to show an example, this is a nevus, and melanoma. You can recognize this as nevus as melanoma. And this is what's called comparative genomic hybridization for the nevus and for melanoma. You can see these are the chromosomes on the horizontal. This continuous lines means there's no alteration. There's 2 copies. And it doesn't take much to realize there's lots of alterations here, so up and down. It's not that complicated of a test to interpret, basically to look at the number of abnormalities, but it's a nice distinction between like a nevus and melanoma. So in cases that are borderline, we use this to try to determine if the lesion, it's probably melanoma or it's likely to be a low-grade lesion or a nevus. So there this would be used if you have ambiguous lesions like this one. So I can't tell if this is a nevus or melanoma just based on histology. I run off this test. So if the test is negative, I favor a nevus. The test is positive, I favor melanoma. So that might be the reason sometimes you get additional testing when you try to diagnose the lesion. So what's the final product? Is the pathology report. That's how it looks. I mean, it has like if you ever read this, there's usually a patient identifier up here. Then you have a specimen identifier where the biopsy was taken from. This is not for melanoma. So this, I see it has a rash on forearm. So it's for a biopsy for an inflammatory lesion. But for a melanoma, I'd probably say, pigmented lesion, give the characteristic of the lesion. There's a preoperative diagnosis, which is, in this case, an inflammatory disease. And then you have pathology diagnosis. So this is the main diagnosis, which is psoriasis from dermatitis. Obviously not cancer in this case. And usually there's an explanation of the diagnosis. A lot of the time, the lingo here is a bit cryptic, unless you're familiar with the medical terms. It's going to be a bit difficult to understand. So it's often better, even if you get your hands on one of these, to have one of the professionals explain it to you. And anyway, at the bottom, these are additional tests. So if one of the tests will be done, will be somewhere at the bottom here, like in this case, there was a test to identify if fungi are present. So it's put here and says negative. So I'm going to end here to summarize what pathology does for melanoma diagnosis. So we mainly use either microscopy to look at this tissue at high magnification or genetic testing to to either diagnose melanoma, stage it, identify the genetic alterations, or predict the response to treatment, or identify the response to treatment. All this is integrated in the management of a patient with melanoma. Well, thank you very much. I think we'll take questions at the end.
It's time for our break. We've had several questions from our audience who is watching virtually. We know you probably have questions too. We invite you to use this 15 minutes to get some more to eat and also to write your questions down, and our volunteers will grab those and get those over to our presenters. Thank you, and we'll see you in 15 minutes.
No worries, yeah. Why don't we do, we can make an announcement that we'll cover your questions.
Yeah, can we do that?
But before, I'm going to show you some of the other ones that came through. Mentioned on that one. We kind of touched on it. Yeah, they've been handing me out some pictures. Yeah. This is kind of, that one's easy, right? Yeah. Well, so then this one's kind of, obviously, this one. How are you detecting diagnosis? Hey, how are you? Hello. Good job.
You can't jump me.
Watch it, Buster.
I think you're next.
Am I next?
You jumped the queue.
I'm sorry. I'm living with Brits all around me right now. So yes.
I understand.
I didn't change.
We still appreciate you doing it. I'm sure it's a new.
Sven, I think these are more for you or for George. This one I can take.
Yeah, they've been handing them to me, so.
It's gonna be cold. We're gonna go into.
It's not very sunny. It's not very sunny. You guys get dry.
I'm willing to do this one.
polarized light. Yeah.
Oh my God, that's what I'm today, and then.
I can do that. Okay, I'll do all those. If you want to do yours. That would
Okay, sure, yeah.
like if you want to, like even great. Yeah, no, I think it makes sense to do.
Plus you carry.
Thank you, I really appreciate it. I'll make
Walking
it.
in all kinds of bad weather. It's not gonna be busy. You should have one line. Still one line, yeah. And actually, can you put in few minutes?
She gave me exercises. You have your real just you said
Water just pouring out.
So how's it going?
Appreciate you doing this.
Oh, there's screening.
Yeah, me too. The good news is that we have so many things that do have.
I was seeing the show. I'm happy to do surgery.
Yeah, I just want to take the baby for anxiety.
I was on the show a couple of times. I know. So yeah, but most of the cases on one side.
So when kids are busy, it's always a little bigger situation.
Well, I don't think I know you were there.
Laura, yeah.
Screening.
Yeah, that's the dermatologist.
Oh, you are?
Yeah, yeah.
So that's why we never seen you.
I guess, yeah. Even in my little corner looking at slides.
It was a long yes. We spent about 5 hours just talking about possible side effects. I was offered just I feel good. I mean, it's, I said I never had, I never know what you say, it was great, but I feel good. So, I'm positive, insufficiency, no overfeel, 100%. I have to taste it right.
Can everyone hear me okay? Oh, I gotta ask him to turn it on.
I'll have to turn it on.
Oh, you didn't? Okay. So you did.
Yeah, but it's fun when it's really.
Oh, okay. So I had a long line.
Good man.
Without any of us.
I know. No, honestly, I think in vivo imaging, that's go DNA.
How about now? Can, nothing?
I think it's going.
Is it going? All right. Hi, everybody. Dr. Prag's going to take some of the questions that were thrown at him now, just because he may not be able to stay for the scheduled Q&A time. So we're going to target some of the specific dermatologic questions that were asked now, if you don't mind listening in a little bit earlier than what the break was planned.
Thank you very much. And we actually got some really, really good questions. So one of the questions is, to dermatology, what does polarized light do to the ability of identifying lesions? It's important to realize that when you use sort of a natural light source, you have a lot of scattered light, and that scattered light usually will come from the surface of the skin, from the scales, and that really limits your ability to see pigment structures. It's still important, though, because the surface structures are actually easier to recognize with scattered, non-polarized light. But what polarized light does is it enables us to actually look a tiny bit deeper into the skin to be able to evaluate some of the pigment structures that are couple of 10 micrometers underneath the surface, and to be able to better comment on that, even with scaly skin. One other thing that we also do is, though even polarized light is not perfect, because if someone has super dry skin, even with polarized light, you may not be able to see through the scale. So often actually we'll also take an alcohol wipe and we'll actually wipe the lesions to make sure that the surface is moist, because that can also enable you to see sort of deeper into the skin and recognize more features. That was one of the questions. The next question was, how often should people with a history of melanoma have their skin examined by a dermatologist? This is actually a complicated question, more so than who asked may realize, but I think it's a super good question. So first, we'd say that if someone had a history of melanoma, then lifelong they should have at least once a year full body skin check by a dermatologist, and that stays. But when it comes to early after melanoma diagnosis, usually there's some laxity in the guidelines, and it depends on what type of melanoma someone had, and it also depends on other factors. Like if someone just recently had a melanoma but had 5 other melanomas previously, obviously we will see them lifelong a lot more frequently, and we will see them a lot more frequently, even if they only had a relatively thin melanoma recently diagnosed, than if they only had a single melanoma in situ diagnosed. So it really is dependent. I think it needs to be discussed with the provider. And I would also add one more thing. It also actually depends on people's comfort with self-skin check and their willingness to take part in their own follow-up. So again, at least once a year. Other than that, early on, usually for 2 years, we do more frequent follow-up, anywhere between 3 to 6 months. In some cases, still even the first 2 years, it's going to be 1 year, and it's dependent on the discussion between the patient and the physician and other factors. Next. Is there a correlation between the increase in melanoma in young adults and the use of tanning beds? To the best of our knowledge, there is. We do believe that sun exposure habits contribute to the very high rate of melanoma in young adults. And tanning beds have been clearly identified as a risk factor for melanoma. Next, is there new research for acral melanoma cause? And this is, again, I think a super good question. I very briefly talked about it during my talk. We need to realize that obviously everyone knows that these acral sites are not UV exposed. We also understand the patterns of mutations are not what we call UV signature mutations in these acral melanomas. Even the genes that are mutated are different. Currently, there's some evidence that suggests that acral melanomas are probably prompted by damage to the skin in these areas. And damage actually can ultimately trigger inflammation, and maybe that inflammatory cascade is what then causes mutations in the skin, in the pigment cells that will eventually result in melanoma, but there's still a lot that we don't know. Next, this is again, I think, an amazing question. Once diagnosed with cutaneous melanoma, am I at higher risk for other types of melanoma like uveal or acral? This is a very, very good question, because currently what we normally and often recommend is that people will still have eye exams. Many of us are not that adamant on telling people that it needs to be done necessarily each and every year, and I think it's reasonable to discuss it with the ophthalmologist. The reason why it's a great question, because overall, if you look at the literature, there's no clear and statistically significant correlation at the populational level, but we need to recognize that subgroups in the population can still be at higher risk. So we do have, for example, a known mutation That puts people at an increased risk of both cutaneous melanoma and also uveal melanoma. And again, therefore, currently what we recommend is that people still get an eye exam and then ultimately discuss it with their ophthalmologist as to at what frequency they should be getting those. When it comes to acral, again, there's no clear correlation between acral melanoma, acral antigenous melanoma, and UV exposure, but one needs to understand that we will still do obviously acral skin exam because having had a melanoma puts you at an increased risk of also non-melanoma skin cancers, and non-melanoma skin cancers can also come at acral sites. So we anyhow will be looking at the skin, but again, when it comes to populational level, the correlation between these is not well established at this point. Thank you.
Next. Welcome back, everyone. Next up, we have Dr. Mary Reed, who's going to be joining us to discuss strategies for screening and prevention in melanoma.
Good morning. I'm the Chief of Cancer Screening and Survivorship at Roswell. I am going to be talking about screening, but I will put a plug in for survivorship a couple times. We have a survivorship clinic. You can self-refer. You can get referred by your oncologist. We offer a lot of support services. We communicate with your primary care doctor. We do a physical, and we get you into, we give you more information because we know there are a lot of residual effects of having been treated, including physical effects and emotional effects. And so we have a really broad program, and you should look us up on the Roswell website. And if you want to come, you can make an appointment. And it doesn't interfere with your follow-up with oncology. So I'm going to just review some of the risk factors for melanoma and strategies for prevention, and talk about melanoma screening, but I'm really talking about skin cancer screening in general. Now, you become advocates for this. You are the teachers in your family and to your friends if you've had melanoma and you kind of know what happens and you want no one else to have melanoma. You have to take information like this and tell everybody. And we have advocates for a lot of other cancers, breast, prostate, now we're starting to have lung. You become the voice of how to spread the word to change people's habits to get away from getting both melanoma and non-melanoma. So your voice is extremely important. There are risk factors for melanoma, UV exposure, from sun exposure and indoor tanning. And there are so many downsides to indoor tanning that even if it wasn't associated with melanoma, we would really want people to stop doing it from a skin damage standpoint, eye damage standpoint. But it is associated, obviously, moles. And, I'm putting this in the language because, we do a lot of screening. The number of moles, the atypical moles, congenital moles, unfortunately, fair skin, which, I definitely have a family history. My husband was a stage 1 melanoma. Our daughter, we lived in Arizona. She learned from age 0, wear hats and sunscreen and stay out of the sun. And because we know that there is a familial association and familial melanoma. And Dr. Parab mentioned that there are some inherited mutations that can change your risk. Previous skin cancers. So when you've had a melanoma, if it's an early stage and it's removed, you still need to be checked because there is always a chance that even on a very superficial early stage melanoma, you can get another one because you have the ability to grow a cancer. We know there are second cancers that melanoma survivors get that are unrelated to their skin. And so it's really important that if you've had a previous cancer, that you continue to be screened. You have great advocates in your clinicians. You have great advocates in your primary care providers to continue to be screened. Age is a risk factor. So the older you get, and when we look at the epidemiology of it, it's more frequent among people who are older. And that is true of every cancer. So at some point, just getting, older and, it affects all of us. Your risk of any kind of cancer increases, especially skin and solid tumors. And if you've had immune system issues, and this is true of both melanoma and non-melanoma skin cancer, if you suppress the immunity, people who have had transplants, they have a really high frequency of non-melanoma skin cancers that occur after this. So any immune suppression from transplants, leukemia, lymphoma, and so on. And so, again, this is the same message that we give to people who've been treated for leukemia and lymphoma. Now you really have to be surveil for other solid tumors and including melanoma and skin cancer. When you look at, this is standardized by all ages, 100 per 100,000 people, you can see that New Zealand and Australia have a really high frequency, both for men and women. And, they get the double whammy. They get the fair skin, because the predominant population down there came from England. So they're really fair skin, blue eyes, and they have a lot of sun. And the Australians have been really leading the world in prevention of sun exposure for their population. They were the first to come out with total, get total bathing suits back in fashion with hats. And if you go there, you really see how aggressive they are in trying to educate their population. But Northern Europe, and again, North America, you can see that we really lead as opposed to the rest of the world, Central America, Eastern Africa. Now, it's not that these cancers don't form in people with not fair skin, it's just less frequent. And I think the providers that you probably see at Roswell can explain the effect of not having completely fair skin on the incidence of melanoma. We can rely on these guys. I'm gonna, because we've talked a lot about the UV. Again, the world incidence of melanoma by age. And so you can see that really, as you start to hit the 50s and 60s, the slope goes right up. And again, that's because we have fewer surveillance of DNA problems. Our age dampens our immune response. This looks the same for many cancers. Regardless of this, is smoking. And it also bears a resemblance to that 50 to 60 for non-melanoma skin cancers like basal cells and squamous cells. It's around that time that our physiology really begins to change, and that accumulation of all that exposure that we got in our lifetime starts to hit us. And that's true of many other cancers, but particularly with skin cancer. This is the way people like me look at risk for cancer. So when it says tanning beds, tanning with redness, a risk estimate of 2 is essentially a 1 is no additional risk, and 2 is twice as much. So there's a doubling of the risk. Not an 80% increase, but an actual doubling of the risk for tanning with redness, with sunburns. And again, that's an accumulated exposure, 2 to 3 sunburns per year. I mean, I grew up, and it's, I don't have any melanoma or skin cancer in my family yet. I'm still, going to get there, but we used to use baby oil and go to the beaches in Rhode Island and come back and our skin would peel, and we just thought that was hot, So that's why folks in our age group, because I'm in my 60s, we really need to be vigilant. And, I'm looking around the room, and your friends really need to be vigilant because we all had similar habits. I'm always stunned. I lived in Tucson for 20 years, and folks would come from the Midwest and spend, the winter in Tucson, which is essentially like the summer here, and really bake like crazy, and then go home. And, that is so dangerous because it's so unregulated, and the sun is so strong there. But that's what happens to Florida and Phoenix and Tucson as well. And again, those blonde hair, red hair, multiple oddly shaped moles, the more moles that you have, the more that these can be risky. Now, there are a lot of folks, and your providers are going to tell you, that have tons of moles, and not one of them progresses to melanoma. So if you start to combine having multiple moles with, sitting out in the sun and getting a lot of skin cancer, your risk obviously goes up. And as you age, that, again, your risk goes up. Characteristics related to risk of melanoma. And it's people with a lot of moles that are unusual. And that's, we run some screening events here for prostate and for breast cancer. And the single most popular one is skin evaluations. We can usually do 250 to 300 people a day, and they are booked out immediately as soon as we tell, because people worry about their skin. It's the organ they can see, and which is great. And we've yet to find a melanoma in the last years that I've been here, but we find other things, non-melanoma skin cancers, and a lot of some of these funky things that you start to grow as you get older that get evaluated. But again, it is something people are thinking about, and I think it's great. And again, we give a lot of messaging on changing some of those habits that contribute to getting a melanoma. And I don't need to read through these because I think this is, again, but just to reinforce this message. From tanning, skin cancer is the second most common cancer among women in their 20s. And we're really talking about melanoma, and we're talking about non-melanoma skin cancer, which actually changes in the skin, AKs and things like that. But melanoma is, we know that it's because there's all of this emphasis on tanning. We don't look healthy unless we have some tan. I mean, I spend most of my time, if I'm not outside during the winter, I'm in my office, and I'm like the palest person of all my friends, because I don't go outside. I use sunblock. And there are a lot of us that do that, but you still don't look as healthy as the person who went down to Florida for their vacation. And that is a cultural value that we have. And eventually it is accumulating. So we are seeing an incidence of younger women getting melanoma. We see some trends with colon cancer getting younger. We've seen some trends. We think they're not blips anymore of other solid tumors like lung cancer, but this is definitely a real trend. Tanning bed users under the age of 30 increase their risk for melanoma by 75% because they're really religious about it. They think that it means that you can tan and then you can go out into the sun and you don't burn, but you're hiding your burn. And so for anyone with a young person they know who uses a tanning bed, you really have to send a strong message to them. And again, it's about accumulation of damage. And, we think this is funny, but this is, what people go through to have a skin tan. And again, it's really high value. You notice it because I'm not from here, I notice it very much in the culture in Buffalo with a dark tan, especially in the wintertime. For non-melanoma skin cancer, Again, the incidence of these cancers really start to increase when you're in your 50s and 60s. They're usually in sun-exposed areas. There are some environmental factors which contribute to non-melanoma skin cancer, arsenic exposure and smoking and radiation. In the South, where you get a lot of arsenical pesticides, farmers, and they do that here too, get exposed to arsenic, and that contributes to some things in the palms of the hands, and also contributes to non-melanoma skin cancer. But again, any kind of constant damage to the skin from ulcers and other skin diseases, and obviously there's a genetics that play a role in having prior skin cancers. So in terms of prevention, I actually worked on an element called selenium for many years to prevent skin cancer, non-melanoma skin cancer. We had multi-centers around the South for the most part, and it didn't do anything. But what it did show, and I met a lot of really senior dermatologists down there, is that where they had folks working on farms for their whole life, starting at the age of 5, and their left arms would be covered with non-melanoma skin cancers, where their right arm, because the left arm hung out the window of their trucks, it is an accumulated event. And so, we think we can't even get enough sunshine to see the eclipse, but we do get in the summer a lot of sun exposure. So again, it's minimizing that damage and the accumulation. The other thing is, it's not as if non-melanoma skin cancer doesn't have issues. It can spread. It can, you see friends and people who've had surgery around very wide margins, because that, especially squamous cell, has spread, and it is not a benign lesion. And that's why when you go into the dermatologist, they also treat those lesions very seriously. And the importance, obviously, is for the early diagnosis. So I promised, I was going to add a picture of my brother-in-law's heel. Okay, so he lives in the UK. He's a big guy. As far as I'm concerned, he's never been in a bathing suit tanning on a beach, but he did have a melanoma diagnosed on his heel, and it was like a dirty splotch that he had for 8 years, until finally he was with a clinician to treat something else, and they said, "What's that?" And they biopsied it, and it was one of these melanomas that should not metastasize, but it did metastasize up into a lymph node in his groin. I was like, Roger, you had it for 8 years. Why didn't you do anything? You go to the doctor? And it was just, I think, somewhere in his subconscious, he was really worried about it. But fortunately, they found it. He's went on to immunotherapy. And, he seems to be doing pretty well. He has some severe side effects from having had the lymph nodes microdissected or dissected. And while they were doing a PET scan, they found a prostate cancer, which they also treated. So, paying attention to providers. So with you are in a good system where somebody's watching over you, but you need to really be diligent, again, with how you message to your friends, to not sit back and think something's going to go away. They should have it looked at, just to rule out. When you go to the dentist, your dentist is looking for lesions in your mouth. Your eye doctor is looking for lesions in your eye. And your primary care doctor should be doing at least, if you're not coming here, to do a skin exam. Because again, early detection really changes the stage of treatment, and that changes the consequences of treatment and survival. I don't want to belabor the point, but using broad spectrum sunscreens, avoiding long periods outside, seeking shade, and staying out of intense exposure. Long sleeve shirts, you can get them. They're stylish. They prevent exposure on your arms, and avoiding tanning. staying alert to your changes in vision, and wearing sunglasses for UV protection. And again, this is just a repeat of the message, but there are a lot of things that you should start young and cover up. The other part, and I'm not going to read all this, but it's really about knowing yourself and paying attention. And, we're not really great as a society in telling people, you need every part of your skin at some point evaluated, from your back to your genitals to your hair. Those are the ones you want to avoid, but melanomas can form in those areas, the non-sun exposed, and you need to pay attention, and you need to send this message to your family that they need to pay attention and go to a provider that they trust and have a full exam. That's what early detection is about. And anything suspicious, you feel, I work with firefighters who also are at risk for skin cancer because they spend a lot of time outside. I mean, that cultural group, they don't want to talk about anything. They don't want to whine about something that's been irritating them for a long time, but it's really important to have it looked at. And then it's great if someone can tell you that it's not important and it means nothing. That's the reward of bringing something up. And, this is what doing a full body exam is about. So I'm sure if you've been coming to Roswell, you are probably more of an expert than I am in this. But again, I really encourage you to be the advocates and talk about it in your group and in your family, amongst your friends. And the other thing is that if you're interested in coming to our clinic, we have a lot of access to a broad spectrum of support services, from physical therapy to nutrition to any, alternate. We do some integrative medicine, but we really do try and get you engaged into anything you need that is a consequence of being here, because we know this isn't just a normal walk in the park. So if there's anything you need, please reach out to Survivorship. We have a great team. We have a clinic here, and we're opening a clinic out in Amherst to make it convenient. And it's called Survivorship. And I'll take any questions, and I thank you for inviting me. Oh, okay, great, thank you. Oh, they're coming in?
They'll come into that.
Okay. I should-
Okay, hello, good morning. Thanks for being here on a Saturday morning. My name is Joe Skitsky. I'm one of the surgeons here at Roswell. I focus on melanoma, and I want to thank Dr. Switzer for organizing this meeting. And I do realize that everyone here in the audience and online has been directly affected by melanoma or indirectly with family members. And so I'm going to talk about surgery, and I'm going to talk about my experience over the last 15 years of being a melanoma surgeon. And those 15 years have been a complete revolution. And so I'm going to share the good news with you about melanoma, and hopefully, everyone will see it. And so I have no disclosures. And just to reiterate, because you've already seen this and probably are well aware, melanoma is a cancer of the melanocytes. Dr. Prague went into good detail about how that develops and what that represents. And it usually starts superficially and has what we call a radial growth phase. So it grows out and then it starts to grow vertically. And so that's why we talk about early detection. It's important to see that radial growth phase before it starts to grow vertically. And if you catch it early, the earlier the better, because melanoma can spread to other parts of the body. The lymph nodes is a very common area that we talk about, but other vital organs as well. And the risk really is based on the thickness. And so the thicker it is, the higher the risk is that it can spread, come back, and cause problems. And so that's why we talk about the early detection. And so the only way to, and again, two features that we talked about, and you've probably heard about it through most of the talks. The thickness is actually the most important feature, and if you look at it, this is how it's kind of weighted. And if you look how thickness and ulceration are weighted, they outweigh all of the other factors, by several fold. And so these are the two most important features, thickness and ulceration. And so ulceration actually is a loss of the overlying epidermis. And that's probably for two reasons. When we know that melanomas have ulceration, we know they're more aggressive. And that's probably because they're just growing very quickly, outpacing the rest of the epidermis, but also most likely they're making factors that destroy the overlying epidermis. Those factors that destroy the epidermis are the same factors that allow the melanoma to get into the vessels, into lymphatics, and to spread. So if you have ulceration, that's why that's such a bad feature. That's why it represents a higher risk melanoma. And so the only way to actually figure out if a lesion, a suspicious lesion, is truly a melanoma is to do a biopsy or to get a piece of the tissue. And Dr. Andea presented the dermatopathology side of it, where we get the biopsy, it gets processed, they evaluate it. And the reality is that you can have a lesion that looks exactly like melanoma, and you won't know, you can't say it's melanoma until you actually see what it looks like under the microscope. A diagnosis really requires tissue, okay? And there's no way around that. And that's part of the role of surgery and dermatology, is that we grab tissue to figure out what the lesion actually is. And a good example of this is in pediatrics and adolescents. There's a lesion that looks exactly like melanoma on the surface when you look at it. And underneath, when you biopsy it and pathology looks at it, it's something called a Spitz nevus, which is completely benign. So really, you can have lesions that are suspicious and may not have the usual features of melanoma, and it takes a biopsy to figure it out. And so there's an old saying, it's kind of crude, but in medical oncology, there was a saying that no meet, no treat. Okay, so if you don't have a biopsy, you're not going to get any treatment because you don't know what it is until you actually see it under the microscope. Radiology has the same thing where they say radiation therapy has the same saying, which is no meat, no heat. And so you really need to see it and prove what it is. And so, as I mentioned, the thickness and ulceration are incredibly important because it leads to the staging. And the staging is really just these two features in terms of T staging. And so you can see that the T stage increases as the thickness increases. And if you have ulceration, that's a differentiation between A and B. And the survival difference is actually very different. If you have ulceration, your survival is actually going to be less. And so this is the two most important pieces of information that we need. And this, again, could be done with something called a punch biopsy. Some of you may have had punch biopsies in the past. This is where it takes a core of tissue. It's not a physical punch. And it grabs a core of the full thickness. And it gives you those two pieces of information that are very important, the thickness and if there's ulceration present. These are very well tolerated. It's just a little numbing medicine and then sometimes a stitch on the outside. But for the most part, it's very well tolerated. And then if you have a diagnosis of melanoma, typically you'll see me or dermatology. And what we talk about is a wide excision. That's the definitive treatment for all melanomas. And you want to make sure that you know the thickness and ulceration because those features determine how wide around the melanoma you go. And so historically, and this is based from 1907, you would do 5-centimeter margins. That's a lot. That's like 2.5 inches all the way around. And so that was based on a single path report on an autopsy series where a patient had a melanoma and they had lesions that were 5 centimeters away from it. So they recommended 5-centimeter margins for everybody. And that sounds crazy, and that's 1907, but that actually went on until the 1980s or so. And so we went to 4-centimeter margins, and then in the 1990s, 2-centimeter margins. And I'm going to talk a little bit about that too. So it's become less and less morbid. And so you measure around the melanoma lesion and it creates a circle. You can remove a circle, but you can't really close it. It's kind of awkward. So you have to make it into this eyeball or football shape so that when it closes in a straight line. And as I mentioned, the thickness of the melanoma determines how wide around it you go. And we actually have very, very good data to suggest that anything that's more than 2 millimeters, we do 2 centimeter margins. Anything that's less, it's usually between 1 and 2 centimeter margins. And this is based on clinical trials that have gone on over 100 years. This is some of the best data that we have in all of medicine, some of the clinical trials that we've done for melanoma. And typically we talk about the cosmetics of this. You want to do 3 times the length to the 1 times the width, and if you do that, it closes in a nice straight line with very few, like we call dog ears or raised edges. And if you do it, less than 5% of patients will need a skin graft or anything like that. Most of these will close primarily. And so this is what it looks like when you excise it. You have this area that can close in a straight line, as I mentioned. There are some areas that you can't really close. If the skin is really tight, you're not going to bring it together. And this is something called healing by secondary intention. This is actually a very nice way to heal. This is, you saw some pictures of what we call acral lentiginous melanomas on the hands and feet. And sometimes on the palms and soles, you're not going to bring the skin together. And so you can actually allow it to heal. It fills in with what we call granulation tissue, and then the skin starts to grow in over the top. It's a very natural process. And so the skin that develops over top is very functional. It can callus. It's, most people don't even notice it. But the only problem with this is it takes time to heal. It is an investment of your time. Usually it's about 6 to 8 weeks for this to completely heal. But it is an option for certain patients. And so that's the definitive treatment for melanoma, and we still do that. That's standard of care, wide excision. And then the other role we have as a surgeon is to potentially further stage the patient with testing the lymph nodes. So we talked about T stage, and now we're going to talk about N stage, which are the lymph nodes. And this whole idea of the sentinel lymph node concept, this came about actually in 1995. And it was developed because in the past, if somebody had a high-risk melanoma, we knew that the melanoma typically would spread to the lymph nodes, and people tried to stay one step ahead of it. So if you had a high-risk melanoma on your forearm, they would think about removing all the lymph nodes underneath your armpit to try to stay one step ahead of it. The problem with that was that removing all the lymph nodes caused a lot of problems that I'm going to show you. Also, it was very nonspecific. There was really no clinical or overall survival benefit to doing that. And that's what we used to do up until 1995. And then in 1995, Dr. Morton in California came up with this idea of the sentinel node. The sentinel node is like the sentinel soldier. It's a soldier that's out front and warns all the others, so that if you remove the one lymph node that is responsible for the drainage of the area of skin where the melanoma developed, and if there's no evidence of melanoma in this lymph node, you can pretty much say with 97% certainty that there's no other lymph nodes that are involved with melanoma. And so the sentinel node test was really nice because you're only removing 1 or 2 lymph nodes, and you don't have to remove all the lymph nodes in that area of the body. And so this can be done by injecting the area where the melanoma was located with a radioactive tracer. That tracer gets taken into the draining lymph node. We can find that lymph node, and so we can do both of these at the same time, where we do a wide excision, and then we remove the sentinel lymph node at the same setting. That sentinel node, you have a handheld probe, you can actually find the radioactive signal, and then you can kind of zero in on it. And it's very nice because it could be a very small incision. You remove the node completely, and then pathology can look at that lymph node in good detail. So for example, when we remove lymph nodes for colon cancer, sometimes we remove dozens and dozens of lymph nodes, and it's almost impossible to look at sections or slides of all of that because that would be tens of thousands of slides. So typically in the past, we would just cut the lymph node in half and look at the surfaces. But with melanoma, and if you're only having 1 or 2 lymph nodes, they can section through the entire thing and look at the details of microstaging. So there could be microscopic deposits that you would not pick up if you just bivalve or cut the lymph node in half. And so this sentinel node biopsy or sentinel node staging has allowed for microstaging. So it actually has been very effective in further kind of prognosticating or staging the patient. And so I'm going to go into what all of this means, but I'll share this too with you so that some of you may have had a sentinel node biopsy in this room. And what's interesting, and it's kind of reassuring, is that patients that come from Canada or across the border will have their sentinel node biopsy. They'll get injected with the radioactive tracer. And I actually feel much more confident in our borders because when they head back, they set off the alarms. And so the alarms can actually detect which isotope they have. And so they realize it's going to be, technetium, and they'll be like, okay, yeah, you had a sentinel node biopsy. Or if they had a PET scan, they'll say, oh, yeah, it was this or that. And it's pretty amazing how sensitive it is. And so this radioactive tracer, it's relatively inert. It washes out of your body after about 2 days or so, but it is still detectable when you cross the border. And so this sentinel node biopsy, what does this mean? This is, again, a very large clinical trial. It was called the Multicenter Selective Lymphadenectomy Trial. Roswell Park was a part of this trial in the late 90s, early 2000s. It had around 2,000 patients, and they were randomized. So they either had wide excision and sentinel node or wide excision alone, and then both groups were followed. And so the real, question was, is there a survival benefit? If we test the nodes and we find melanoma early, are you going to live longer because we can deal with it sooner and treat it sooner? The reality was that both groups did exactly the same. So that if you didn't have your lymph node tested, but you developed a lymph node later on down the road, the lymph node became enlarged and palpable, you can remove the nodes at that point and the patients would do exactly the same in terms of their overall survival. However, the sentinel node did give really good prognostic information. So for example, if your lymph node was negative on the sentinel node, we knew that you're going to do much better than your original staging. And so it's a really good prognostic test, but it really did not influence overall survival. This could change over time because this is before we started having the modern immunotherapies. And so there is potential that changing the stage could change the outcome in terms of what the patient receives afterwards. But so far, there's no definitive evidence that sentinel node biopsy changes overall survival. So what came next is MSLT2. It was the next iteration of this big clinical trial. And again, Roswell was a part of this in the mid-2000s. And we contributed a number of patients to this study. And, again, we talk about Buffalo being the city of good neighbors. Man, it's a city of good neighbors to the whole world. Some of the data that has come from MSLT1 and MSLT2 has influenced how melanoma is treated across the world and in a good way. And so what this study showed that if you had a positive sentinel node, the automatic reaction was to remove the rest of the nodes in the area. Was that necessary? So it split the groups into two, where if you had a positive sentinel node, you had your lymph nodes removed immediately versus just following it very closely. And if something developed, then dealing with it if it developed. And it showed very clearly that you do not need to remove all the lymph nodes immediately. And as a matter of fact, a good 80% of patients never go on to have their lymph nodes removed. One of the surgeries I used to do, and a lot of the surgeries I used to do, like lymph node dissections of the axilla, lymph node dissections of the groin, I hardly do them anymore. And that's awesome. So patients don't have to undergo these extensive surgeries. They don't have to undergo problems that can happen with these surgeries. If you remove all the lymph nodes underneath the armpit or the groin, you're at risk for lymphedema or swelling, and this is not insignificant. Some of these people are wheelchair bound because they're not able to walk. All the fluid, it's about extra 20 or 30 pounds of fluid. If this is your dominant arm, you're not going to be functioning very well. And so the fact that we've gotten away from a lot of the surgeries that we used to do is just a really good thing. And that kind of leads us to the idea of this era of de-escalation. So in the 15 years, the things that I used to do are completely different and a lot less, and definitely a lot less morbid for patients, and the outcomes are better, like way better. So for example, if I saw somebody when I started in 2009 and they had enlarged lymph nodes for melanoma, We did surgery and extensive surgery because that was the best option, that you had to get around it, and that was your best shot at getting rid of it. That, again, even with the best preventative treatments we had afterwards, probably about 75% of patients would eventually develop recurrence and die. So 25% survival rate back then. Those numbers now with modern immunotherapy, you remove the nodes, you gave immunotherapy, those numbers bumped up to about a good 50% of patients that were going to be alive. Now we're going to talk about this neoadjuvant, and Dr. Puzhinov, who's following, is going to talk in detail about it, but you can jump, the numbers are significant, up to 75% overall survival, and then in some groups with combination immunotherapy, the vast majority can have over 90% survival. So these numbers are just absolutely mind-boggling. And so the good thing is that we've been able to de-escalate surgery, so we're doing less and less, and the patients are doing better and better. For example, with melanoma, in the past, we would do amputations, and then it became wide excisions with 5-centimeter margins, became 4, then 2, and actually right now we have a trial going on with one of my partners, Dr. O'Brien, who's looking at 2 centimeters versus 1 centimeter. So it's becoming less and less invasive. As I mentioned, we used to do elective lymph node dissections, and then sentinel node biopsy was developed. And now, in the past, when somebody had a positive sentinel node, we would do a lymph node dissection. That's obviously not necessary anymore, and we do nodal observation. So things have changed dramatically. And obviously, it's all because of immunotherapy. For the most part, we talk about the modern immunotherapies, and we talk about the historic use of adjuvant versus neoadjuvant. Adjuvant means that you get treatment after surgery to try to prevent the melanoma from coming back. Neoadjuvant means you get treatment while the melanoma is still intact. And I can tell you, as a surgeon, when somebody comes to me with a diagnosis of melanoma, they want to have the melanoma removed yesterday. They want to be out, done with it. That may, actually not be the best option at this point. And clearly you could win the battle, but you can lose the war. As I mentioned, those numbers where we talk about percentage of people that have good outcomes. If you have the same immunotherapy and you give it as an adjuvant, about a 50% chance that this melanoma is not going to come back or cause a problem. But in this group, in this large clinical trial, if you gave it as a neoadjuvant, you gave it while the melanoma was still intact, and you give a couple doses before surgery, the outcomes are dramatically different. It's the same medications, same everything. It's just that the tumor is intact and can actually act as almost like a vaccine, where it primes the immune response so that using the tumor in situ is to your advantage. And so being in a rush to remove the tumor may not always be the best option. And the nice thing about this neoadjuvant approach is that you can get treatment and then you remove the tumor, and that's what I've been doing surgically now, and you can gauge how good the response is. You could say that, oh yeah, like 2/3 of patients received we call a major pathologic response, where there's less than 10% viable tumor. Sorry. That's my timer. So I'm going to go right through this. So 2/3 of patients have a major pathologic response, and you can evaluate that tumor deposit, and it kind of dictates how treatment's going to go. So if you have a great response, you don't require anything else. No other surgeries, no other immunotherapy, no other adjuvant treatments. And again, this is the vast majority of patients at this point. Just to show you that this is now one of the surgeries that I do, and it's actually very minimal, where somebody has a tumor where they present with a melanoma. We put a little probe in the tumor. They get their immunotherapy, a couple doses, and then we can actually use that probe to find where the tumor deposit was, because sometimes the responses are so good, the tumor kind of just melts away. And so we can find it, and that's called the index node, and then we can evaluate it for a response. So the bottom line is that surgery has changed dramatically for melanomas. Melanomas used to be a disease strictly that was, surgery used to treat all stages. That has changed dramatically, so that surgery has become second, fiddle, I think, to medical oncology and some of the new immunotherapies. And it's, I think, fantastic for the patients. And that's all I have, and I can take questions at the end.
So that was excellent, and I will tell you about the neoadjuvant therapy. Actually, Dr. Skitsky and Dr. Switzer kind of summarized, what we do in there. Stay tuned. There will be a definitive trial presented at ASCO this year called NADINA, which is basically taking that approach and making it in a more patients. The data will be presented on June 3rd, which is Sunday, which kind of tells me it's going to be a plenary session, although that has not been officially announced yet. But that's what it will be. Actually, June 2nd, not 3rd, June 2nd. So I will tell you about the metastatic melanoma. So when all this fails, the surgery fails to cure the patient, the neoadjuvant or adjuvant therapy fails to cure the patient, patients develop disease in other organs, metastatic, unresectable, and these are my disclosures. And then what we do. So you'll see kind of these 3 different approaches. I'll be talking about the bottom one, which is the systemic therapy for advanced melanoma. So traditionally, the therapies were few. In the 80s, we used the carbazine, that was the chemotherapy. That was actually approved on one trial with like 70 patients, where 10% of them had a shrinkage more than 30%, and that lasted less than 4 months, but there was nothing else, so they became a standard. Then Dr. Rosenberg, actually, who is a pioneer of immunotherapy at NCI, pioneered the approach with interleukin-2, high-dose interleukin-2, and he also at that time pioneered a treatment with what he called LEC cells, lymphocyte-activated cells, killer cells, or tumor-infiltrating lymphocyte cells. And I'll come back to it at the end, because what was once old, is now new. And you may ask, why was the interleukin-2 approved, in the 80s, but not the cells? And the reason was that when FDA looked at his data, they kind of understood about the, how the interleukin-2 feeds, activates the immune cells and helps the patient, but they couldn't really get their head around, the mixtures of cells come in and what they do and, how you select them. So they said, do more work on the cells. And we actually get approval just for what was really to support, the cells. And you can see the outcomes were pretty dismal. In the 36 months after your diagnosis, almost everybody died. And when you look at the typical 6 months, that already 50–60% of patients died. So the median kind of patient, the middle one, not too good, not too bad, was alive between 6 and 10 months. And that was state of the art until these 2 mechanisms came, and you heard about them. One is the immune mechanism on the left, and one is the kind of a tailored, targeted mechanism taking advantage of the vulnerability of these tumors, which is the BRAF mutation. And so that's what happened, and this is like how it went. And I was lucky because I was part of all of that, like started in 2005 when I became faculty at Vanderbilt. And even when I was a fellow, we had trials with ipilimumab, that's the CTLA-4 antibody. That's what Dr. Ellison got the Nobel Prize for. He's an accomplished harmonica player. That documentary movie Dr. Switzer alluded to, I encourage you to watch it. He actually played on stage with Willie Nelson, and he plays in the group, which is our traditional Society of Immunotherapy in Oncology group, which was a bunch of nerds. For many years, nobody cared. And he gets drunk and plays harmonica. He's a really fun person. I love him. And there are other accomplished people who used to be young and inconsequential. And now when you go to these performances, which we have at all different meetings, like American Association of Cancer Research, you always hear performance by checkpoints. And everybody who is on that stage is like Cancer Center Director, member of National Academy of Sciences, and they do a lot of good music. So that's a lot of fun. And You can see vemurafenib there. That was the first BRAF inhibitor. Then we figured out you are better off giving it, in combination with MEK inhibitor. It's all on that pathway. That's trametinib, and it's like one by one. You see pembrolizumab and nivolumab, close by. These are the other checkpoints, the PD-1, the programmed cell death ones. Then you see the combination between ipilimumab and nivolumab. Put them together, they are better. I'll show you data. Then you see something called TVAC, which was, really kind of a work of heart. Nobody believed in it. That's actually oncolytic virus. You take a herpes virus, you modify it so it cannot infect people, so it's like harmless, and then you put, some, like some molecules to stimulate immune system, and when you inject it into tumors, you may make them disappear, some of them, and it's really good for patients who want to avoid some of these toxicities Dr. Switzer talked about, and at the same time, they want to, they have some tumors and the surgery would be too extensive. Let's say if you have 10 tumors on your arm, having a surgery would be pretty debilitating. On the other hand, they are not doing much to you. So you worry about all these itises because you can die from them. And so you say, well, why don't we just inject them and see what happens? And sometimes it happens good things and it's all good. And if not, you can always go to the stronger treatment, because then you need it, but you actually may potentially avoid those side effects. Then you have additional combinations of targeted therapies. And then as you can see, we even have a one triplet combination. That's the atezolizumab, vemurafenib, and cobimetinib. That's kind of like a dead child born because it's pretty marginal. And actually, although they met the primary endpoint, when the investigators looked at responses, but they didn't actually meet the same criteria when like a radiologist looked at it. So you tell me, when an investigator looks at something, they tend to be more optimistic. When a person who has like no vested interest looks at it, if the effect disappears, we really don't use it really at all. Then there is the nivolumab relatlimab. I'll talk about it. That's a new kid on the block. It's a different checkpoint inhibitor. Relatlimab, hits another pathway. And then tebentafusp, I put it there because it's the first and only drug for eye melanoma. And I have been involved with it since 2015. And it is really a new novel, mechanism. And but it's not used in skin-based melanoma yet. Maybe never will, but it opens some door to other drug development. And last but not least, as of February of this year, lifileucel, that's the cell therapy. That's actually the tumor-infiltrated lymphocytes, which I told you were actually studied by Dr. Rosenberg in the 80s. So that's really what it is. And so what do? We have a patient, and let's say the patient has a metastatic melanoma, and the metastatic melanoma you test, with pathologists, and they have the BRAF mutation. So in the old days, we didn't know what to do because some people gave the targeted therapy, and that was good. Some people gave the immunotherapy, and that was good. And then people, of course, had a lot of discussion which one is better. So instead of discussing, it's better to do trial. So these are two trials. The first one with the 3 arms is European, SECOMBIT, and the other one is American called DreamSeq. Took us a long time to figure out a catchy name. And what it is, you take those patients, you randomize them, and half of them, will get the targeted therapy first, the other one immunotherapy, and then if they have progression, you kind of flip it, to the other treatment, and you see which one sequence is winner. And Italians, they did a third arm where they actually kind of gave the targeted therapy first, but only for 2 months, and then again they gave the immunotherapy and went on. And what happened, this is actually the DreamSeq data. What you can see, the black curve is the winner, and that's the curve where you give the immunotherapy first. And the red, curve is the loser. That's where you give the targeted therapy first. That's why we rarely use the targeted therapy first. But you can see at the left, right here, that the red arm was a little bit better at the beginning. But as you can see, all these patients are doing poorly because 100% are alive here, and only about 60% are alive here. And when you look down, that's like 8 months. So these are the patients who have the primary refractory melanoma, like a bad one, and they kind of die on you pretty quickly, and it's about 3 out of 10. That's the last trial I would like to do in my career, to figure out how to help this group. And of course, you can see they do a little better with the targeted agent, but no cigar, because the difference is what, 2 months, 3 months, and then they die again. So these are the patients of unmet need. We hope to have something for them, in next 5 to 10 years, maybe something radioactive, like radioactive antibody, maybe something similar. But that gives you an idea. So if somebody asks, I have a BRAF mutant melanoma, no matter what the internet say, or whatever people say, you tell them immunotherapy is the winner. That's what you should be having first, and then you can have the other one second. And that's the overall survival. Again, you can see that top group, dying pretty quickly. Again, 10 months, 20%, are not here. That group seemed to be doing a little better with the targeted therapy, but you come to this joint and that's it. And long term, the winner again is if you give immunotherapy first. And you can see there is actually a big difference. So giving targeted therapy first, actually, I would argue is almost malpractice unless you have a good reason for it. Because if you start with targeted therapy, this is how people end it. And remember, they were allowed to get immunotherapy later, but it didn't make up for that initial deficit. So immunotherapy first. Combination immunotherapy, in this case, it's ipi/nivo. Better outcomes. Not every patient, but again, that group where the target therapy is better, it's better by just a couple months. And the nice thing about the targeted therapy, I will just point to you this. What it means is whether you give it actually upfront or whether you give it after immunotherapy, you still have about 43–48% of patients responding. So, when people say, yeah, but I would like to get a targeted therapy, it may not work later. It actually works later also, so you can safely defer it to the second line. And so that's really what it says. So for a stage 4 melanoma, regardless of the BRAF mutation, one should start with a combination immunotherapy. And if a patient progresses, the targeted agent can be left for later. But what about that new combination? That's the combination not with nivolumab, ipilimumab, but it's the nivolumab relatlimab. So this is the plenary session of Relativity 047 trial. And as you can see, they were looking at progression-free survival. These are patients, again, 100%, not progressing here with melanoma stage 4. They have BRAF mutation or not, it's a mixture. And again, you can see that some people progress very quickly, that's really the same group, we still need to do something for them. But then the curves separate, and the blue one is the combination of the relatlimab, nivolumab. So it's better than nivolumab alone. That's why when you come to my office, we actually try to give you combination of immunotherapy. And what is actually nice about it, that all the different groups, were helped. And when you look at the BRAF mutation, whether you had it or you didn't, you benefited the same. The dotted line here means that it's a wash. If you see this little ball on the left side, the combination is the winner. And the blue lines, what they tell you, if they cross the dotted line, then you kind of cannot tell. But if they are firmly here, then it's statistically significant. Then it's like a done deal. You cannot argue with that. So you can see that BRAF mutation, pretty aligned. So whether you have BRAF or not, this is the winner. And these two, just a little for anybody who is interested in detail, you see that PD-L1 expression on a tumor. And if you actually had it, it looked like you can get either combination or the single agent. And if you didn't have it, then of course the combination was the winner. But because this was not how the trial was originally written, in the US, we approved the combination regardless of PD-L1 marker expression. In Europe, where they actually try to be most cost effective, they actually gave the approval in a PD-L1 expression low patients only. Whether it's right or wrong, I don't know, but that's what they did. And the key is, we now have a second combination, and there is a survival curve, and you can again see improvement. But when you look at it, the improvement is there, but is it 100%? No, it's like, 6, 7, 8%. It's significant, but at the same time, we need to do better. So we still need new drugs, to actually help the rest of those patients. But as Dr. Switzer said, and as I said, remember that survival in the old days was here, and we are here. So, we went a long way, and the melanoma was voted, or not voted, it was assessed as the most improved, solid tumor survival by American Cancer Society. So the relatlimab approved in 2022, and here you have it summarized. Response rate means mostly shrinkage, 30% or more. So if you have a, single agent Keytruda, that's dead. Nivo, it's dead. And then you have the Nivorella and then Ipi-Nivo. So Ipi-Nivo seems to have the best shrinkage there. When you look at 2 years progression-free survival, still Nivo, Ipi seem to be the best. But when you look at the survival, they seem to be pretty comparable. And in terms of the toxicity, 60% will have pretty bad toxicity with this combination, but only 21 here. So, somebody who is older, fragile, has emphysema, heart disease, kidney disease, whatever other disease, that combination actually plays a big role because it can be given more safely, and you can always, again, save the more big gun, safer, for later. But I will show you there are some situations where you don't. That's just saying that the BRAF mutation doesn't matter in this combination. It's the same good for both. And this is just to try to, kind of a read tea leaves, if it's better to use this combination or that combination in general. And basically what it is, it's hard to compare, but no idea. They look very similar in terms of survival. We'll see the updates, and obviously everybody and their mother would like to have some biomarkers. What it means is to have some test which tells you which one is better for individual patients. We are working on that with a company called OncoHost, and maybe, just maybe, we will have it, but not yet. And there you have it in summary, that the frontline immune checkpoint inhibition is proven superior to BRAF-targeted therapy, especially Ipi-Nivo. We didn't test Nivorella in that same situation. And there are some small populations which may benefit from targeted therapy, but it's pretty sure they really need new drugs. And the jury is out, whether the nivolumab, ipilimumab, or nivo-relatlimab is better. They may end up being similar, but it doesn't tell you if there are some individual patients who may benefit more from one or the other. And the toxicity is different. The Nivorella is less toxic. So if you say, doctor, give me something which will be less likely to make me sick, give them Nivorella. It's a discussion we have with patients, some of you know, and that's what we do. But some of the patients don't have a choice. If patients come with brain metastases, I actually co-wrote that trial, this one, and that was the trial which we published in New England Journal of Medicine, Checkmate 204. We gave patients the combination of the nivolumab, ipilimumab, and the A, that was the arm of 101 patients who had a small brain metastases. They didn't have seizures, didn't have much headache. And look at it, 61%, had a progression-free survival. 54% had a shrinkage in the brain. If you remember the data I just showed you, that's the patients without actually brain metastases at 65 and 58. And now you are looking at somebody with brain metastases here, and it's actually 61 and 54. basically ipi-nivo works the same in the brain as it works in the body, which is like amazing breakthrough. And but only if you don't have trouble from these brain metastases. These are the patients who had trouble, seizures, headaches, steroids, and look at that, these numbers drop. So this is another area of unmet need. If you come and you have big tumors in the brain, headache, and you are wobbly and having seizures, then that's not good news. And this is very similar trial from the Australian group. And this is the targeted therapy. It also works in the brain. And you may ask, how do we use this? Well, if you come and you belong to that B arm and you are wobbly and you have pain and you have a lot of, steroids on board where the immunotherapy would not work, I give you the pills, have you shrink the tumors in the brain, and then I give you the immunotherapy when you become, kind of stable, no steroids, no headache, no seizures, no nothing, and hope for the best, which sometimes happens and sometimes it doesn't. So patient with advanced melanoma, progresses, and now what do you do? This is a table of all different things you can do after progression on a first-line therapy, because remember, not everybody is lucky to be that 50%, 60% survivor, and you have other things. So for example, if you get ipi-nivo initially, or PD-1 in general, with you can actually salvage some of them with, again, that new combination, because if somebody is on the ipilimumab, nivolumab, they all had a PD-1, 57% had a ipi. So, pretty standard population, 12% actually had a response rate, and median, the kind of a duration of the response was not reached, which means that you can have meaningful salvage, but only for about, 5 to, 10%. So, we still we need something, after the progression on frontline. This is more historical because we don't treat patients like that anymore. But this one I will put to your attention, and that's the cells, that's the lifileucel, that's the latest approval. You can see heavily pretreated patient, and the response rate here is 49%. What this means is that's the pills after progression on immunotherapy. We know that they will work, but they only work usually short time. That's the problem with the pills. They can give you relief, they can get you better, they can get you on either the cell therapy or some trial, but they cannot cure you. And that's the cell therapy. So how does it work? You have tumors, and a surgeon like Dr. Skitsky, will remove one or more of these tumors. We send it actually to the laboratory, and what they will do, they will actually clean up the tumor, the gray ones, from the immune cells, the red, the yellow. See, that's clean up, so they isolate them. It's a mixture, it's a mixed bag. And what they do, they actually now grow them, they actually give them, like nutrition, to multiply them. And this on the right side, if you want it, I don't have time for that, but these are the CAR T cell therapies, which we also try to do, but they are more in the research, that's where you actually manipulate, cells you get actually from the vein. But this is what is approved. This is the TIL cell therapy. And what happens then? So first, you remove the tumor. Then you are making those cells in the laboratory. You admit the patient to the hospital, and you give them some chemo, just basically to make space for those cells, when they come. Now the cells are coming, and you give them, now patient has like a space, to give these cells back, because you cannot give them when there are all the cells, you need to create a little opening, there. And then you give them the interleukin-2, the famous interleukin-2, but not too much, just a little bit to feed those cells, so they can happily grow. And then you have patients recover and go home. It's a one-stop shopping from here to here. It takes about 4 weeks. When you add some lag time, to discuss, wait, and do. And here it's about 6 weeks, time. So ideally, we try to talk to patients who may need this early, because you don't want to lose any time, because still it will take some time. And you can imagine that some patients will have progression before that all is done. And this is a trial, actually, they did in Netherlands, Dr. Hahn, a good friend of mine. And what he did, he took patients who progressed, on a PD-1, like Keytruda or Opdivo, and he randomized them to either those TILs or to give them the ipilimumab. They didn't get the ipilimumab frontline. So you may ask, what about if they got ipilimumab? They were not on this trial. And the data actually looks good because this is the people who got cells, and this is the people who got ipilimumab, so this is good. But when you look, it's about 5% of patients who were really helped long-term. There are some, here who were helped, kind of middle term. And then there is, of course, half of the patients, will progress pretty quickly, So that's something to have in mind, that the cell therapy, although it's good, it doesn't help everybody. But if you are here, you are a very happy person because you are now 72 months and you should have been dead and you are alive, and everybody's happy here. And that's why we do it. But we want to push this rate, eventually higher, but more work is required. And this is the American study, which we participated in. We simply just took the TILs again, and there was no control arm. Everybody got the cells. And the claim to fame is this, the cryopreserved lifileucel, because while the first ones in the Netherlands, they cannot travel. You have to be in Netherlands and get the cells, freshly made. Here, the process is that you can actually make them anywhere, or make them in a lab in a central, location in Philadelphia. And because you can freeze them, that's what it means. Cryopreserved means they're frozen. You can ship them around the world, on ice, and they can travel. So that's the beauty of that approach. And I will show you what happened here. So these are heavily pretreated patients. They have really no good options left. And about 30% of them have actually response. So they have shrinkage of the tumor. About 6% complete response, 25%, good, 30% plus shrinkage, even 50% some stable disease, so it is a good treatment. However, it can be toxic. And of course, it is to be done in centers which have the teams and support available, because you cannot do it in a regular doctor's office. And when you ask how the durability of response is, so if you think 100%, this is the 30% of patients, and about 10%, 20% will kind of drop down, here. So really, again, when you are thinking about it, these are the patients you really want long-term. It's about 50-50. You are really helping from those patients who got the TILs. If you ask, what about these patients? How many of 100 get in the cells are these long-term, survivors? It's actually about 15 to 20%, so it's not everybody, but it's a real number, and if patient is, able to and interested, then we can do it, and there is a 1 out of 5 chance that they will be alive without progression, 4 or 5 years later, which is a very long time. But some caveats, there was a real risk of dying from the procedure. So we really need planning, multidisciplinary support, and all eligible patients should be considered ideally early, where the performance status is better. And that's the opportunity for collaboration with our community partners, because if you don't come to Roswell and you come, to regular doctor, we need to collaborate, because you can be treated there. You can get your Ipi-Nivo, you can get your Nivorella, but if you need TILs, you need to be here. They cannot do it, even if they want it, they cannot do it, because you have to be certified. And, you can use the targeting of the BRAF mutation as a bridging therapy. And, I didn't speak much about the oncolytic virus, but that can be used, for these progressing patients as well. And we would like to get to individualizing the therapy, because a lot of this is kind of lumping patients together. We are not there yet. The breath helps you. Looking at, the immunotoxicity helps you because you may at least gauge who maybe take the toxicities well if they happen and who doesn't. And like I said, we are working on the biomarkers. And one idea is to use the biomarkers early as you are starting, the ipi-nivo or nivo-rela, and kind of gauge or glean, who may be the early progressor so you can get ready with your TILs or other clinical trials. And there is a lot on horizon. We have them, all pretty much here. There is a peptide vaccine coming, whether it's positive or negative, we don't know. But we have a global phase 3 trial enrolled, with peptide vaccine. So you hear about vaccines for melanoma. So we'll see if it's positive, it will be big news. If it's negative, it will be just a dud. But if it's a positive, it will be actually bigger than Moderna. You hear about Moderna, COVID, BioNTech. So we will actually scoop them. So we'll see. Q4 of 2024, we'll have top-line response data. And in Q3 or 4 of 2025, we'll have progression-free survival data, which will tell us if it's a positive or negative trial. And if it's positive, then we will obviously have it. And it's a simple vaccine, like you get a vaccine from your diphtheria or, tetanus. It's kind of a similar, simple, vaccine, not sophisticated like these mRNA vaccines. So I like that. But again, we'll see. Then different cytokines, the interleukin-2 you heard about, but there is 12, 18 others. There are agonists to stimulate other parts of the immune system. There are other ways to engage with the tumor. And don't forget, don't ever count, the targeted therapies out. Because just because these breath MEK, targeted therapies so far were kind of beaten, and they are a little limited, it doesn't mean you cannot develop better one and actually kind of get right back, to the fight. And what I really like, there is an antibody which targets melanoma, specifically, like you have seen, and it's called melanocortin receptor, melanin melanocortin, and they put like a piece of radioactive label on it. And it looks like it could be potentially something good for these patients I showed you who die quickly, those 20–30%. So we'll see how that works. But you have to have some patience for that. And I'll thank you. And I thank Dr. Switzer and AIM at Melanoma and our community outreach team for organizing this wonderful, wonderful symposium and open the podium for questions from all the speakers. Thank you. So I will actually, Dr. Switzer wanted to say a speech.
We got one more talk.
Oh, we have one more talk.
Yeah, sorry.
All right, so I got carried away.
No worries. Would like to introduce Alicia Larson, who's joining us for the Roswell experience at the Resource Center at Roswell.
Thank you very much. I'm very happy to be here today. So I'm representing our 11-day Power Play Cancer Resource Center and the Elevate Salon. Of all of the resources that we have here at Roswell, truly our doctors, our researchers, our pathologists, they're our most fantastic and best resources that we have. But our Resource Center and Elevate Salon offer you some additional support and resources that I want to share with you. So we opened up in our new space just a little bit over a year ago, thanks to a wonderful donation from the 11-day Power Play organization. They're a continual hockey event that fundraises, and they helped us open this beautiful space with the fireplace. So our Roswell patients who are here in person, if you see the fireplace on the first floor of the main hospital, that's us. So we also are grateful for additional donations that came from the Buffalo Sabres and also from West Her, also some local families. And so it really took the entire community to build this beautiful resource center. We're a soft place to land after a diagnosis or truly at any stage of your cancer journey. all of the different, facts and figures and numbers and reports that you get along the way can be confusing, overwhelming, scary. All these different emotions come up, and we want to be a place where you can come in and kind of take a breath, unload, stop in our relaxation room, listen to a meditation, experience some Reiki, have a class, have a talk, this and that, and just try to help you a little bit. We have wonderful cancer education within our resource center. So we have information on all of the different various types of cancer, A to Z, and we celebrate the various cancer awareness months. We provide an infusion orientation where we sit down with patients and their loved ones and talk through all of the different supportive services available to patients across the hospital. Roswell is basically its own little city. We have a little bit of everything, from legal care to financial care, social work, psychology, spiritual care, so many different modalities that can help you through all the various troubles that you could face. We also help point you in the right direction. So you could come into us with any sort of issue, and we'd like to get you to a department within Roswell, a person within Roswell, or an outside organization like this wonderful Aim at Melanoma organization to help you through. We also recognize the importance of our caregivers, and we host many different support groups within the Resource Center, one of which is the Caregiver Support Group. We have a lending library of various books on all different topics, from nutrition to survivorship. We have a lot of memoirs available so you can read the stories of other survivors who have been through a diagnosis. We also have books for children. So to make cancer a little less scary, to make hair loss a little less scary, so you know the words to speak with the children, the young people in your life, to, just make it a little less scary and show them that you're going to be okay. Roswell's got you, and, it's going to be all right. We also have a business center. So if you need to hop on a computer, you can access your patient portal. We can teach you how to use the patient portal. We can get you registered for the patient portal. All amazing things, because all of your results are available in that portal. And we can help you kind of dissect those things a little bit and formulate some questions for these amazing doctors that we have here at Roswell Park. We also have a plethora of different items available for loan. So spend just one day with us. They're kind of long days sometimes. So you can borrow a DVD player, DVDs, laptops, iPads, books on tape that have meditations, information, all kinds of different things to borrow. We also have a lot of different comfort items, so handmade blankets from people in the community. We have port pillows like we have in the back of the room here today, thanks to the Melanoma organization. Also notebooks to keep track of everything that you need to keep track of, chapsticks, stress balls, caps, all kinds of different things. We also run a patient and family tour program. So when you're new to Roswell Park, we can physically walk you through and show you where, the infusion center is, where the financial area is, where the hospitality room is to get a cup of coffee, all of those different things. We also run a monthly care conversation series, and it has a different topic every month. We've done different topics like acupuncture, spirituality, and cancer. Upcoming this month, our topic is on survivorship and survivorship care plans. Do I need one? What are they? How do you get one? We provide wonderful integrative care services. So here on the left is Julia. She's our breathwork and relaxation practitioner. We offer oncology massage. We offer Reiki. We offer a number of different classes. So there's our hand and nail care class, because many different treatments can cause drier skin. And so we have an oncology trained esthetician who comes in and teaches a wonderful class on hand and nail care. We also provide facial classes, soothing skincare classes, beautiful brow classes. So if you're losing your eyebrow hair, in addition to the hair on our heads that we think of more often, We can show you how to draw in your eyebrows. I mentioned support groups, and what's wonderful is that Roswell offers a number of different support groups based on various disease sites and topics like survivorship and those sorts of things. And also we're going to be building a program where we can stream in live support groups from other outside organizations to help increase the number of support groups that we have available for our patients and caregivers. You can also message us in the portal. So we have different inboxes available. You can ask questions about our salon, about getting a visit in your inpatient room, request something from our lending library, ask any questions about hair loss that you might have or RSVP for any of our programmings. We also run an inpatient birthday program. So I get a report every morning letting me know if there are any inpatients who are celebrating a birthday. We dress up a cart and we take up a cupcake and balloons and a card that the entire care team signs, and we sing happy birthday. You know, because these little pieces of our life can really be very big pieces, and we just want to show our patients, you know, that we care about them. We also have resource centers in our North Towns and South Towns Care Network locations. So that's a wonderful thing. And then just a bit about our Elevate Salon. So if a patient is experiencing hair loss due to their treatment, they're eligible for 1 complimentary wig and 1 complimentary hair covering. And we have 2 New York State licensed hairstylists available every day of the week. They provide pre-treatment haircuts as well as head shaves if people are interested. Also thinning, trimming, shaping of these wigs and head coverings. So these are a few of our wonderful patients. You can see our outside of our Elevate Salon on the first floor of the Clinical Sciences Center, a gallery of our patients and the wigs and head coverings and such that they select. You can also check out the website, roswellpark.org/Elevate Salon, and read these patients' stories. We have a wonderful collection of various wigs and head coverings. We've recently expanded, and we've gone from 1 vendor to about 6 with many different brands. And so our aim is to have hair that, you know, so a person loses their hair, we want to be able to provide a wig or head covering that looks and feels like the hair that they lost. Every person deserves, you know, that. So we have a variety of different styles, from straight and fine to curly and coily and textured. We have some hats with hair with braids. We have locks. We have almost everything you can think of. So we're really trying to be inclusive of what every person might like. We also support our pediatric patients and provide ultra petite sized wigs for these patients. We also offer the scalp cooling program through our Elevate Salon, and this is a therapy that right now is in a pilot program available just right now to our breast and GYN patients. And the therapy cools the scalp and prevents hair loss by keeping that hair in the hair follicle. So it's something that we're building. We're hiring on a person to expand this program, so you'll be seeing more about that. We also love to celebrate the victories of our patients, and these here are just a few of our patients that, you know, we meet them along the way. They come to the resource center, they come to the salon, we hear their stories, we walk with them all the way through, from diagnosis through survivorship and beyond, and celebrate their victories with them. So we're your hub. Stop in and see us. The resource center, first floor, main hospital. The salon is the first floor of the Clinical Sciences Center. Both are open Monday through Friday from 9 to 4. And that is that. Thank you very much for having me here today.
Well, here we are at the end of our symposium, and I asked for about 5 minutes, so I'll have the opportunity to talk to you a little bit about AIMIT melanoma and who we are. If you don't know our origin story, Aim at Melanoma was founded 20 years ago by Val Guild after her daughter Charlie was diagnosed at 26 with melanoma. At that time, there was only one treatment for melanoma, to which Charlie did not respond. And after she passed away, Val determined to found an organization that would do two things. Firstly, to try to find a cure for melanoma. And over the last 20 years, what we determined to do in terms of that is to fund research to establish 5 tissue banks across the United States where we collect fresh, frozen primary tissue. We have been collecting that now for about 10 years. We are almost to the point where we have a sufficient number of tissue that we would begin to be able to offer it to researchers. In addition to that, while we are collecting that tissue, we have been trying to support people who are living with melanoma, and that largely comes in the form of education through our website. Let's see if I'm technical enough to do this. I'm a people person and not a technical person, so you'll forgive me. I want to introduce you to our website. We want it to be one-stop shopping for you in terms of information. AIM believes that a well-educated patient is a better advocate for themselves, and hopefully, therefore, will have better outcomes. I hope you'll allow me to say that. Our most frequently website pages that people visit are stage and their relevant treatment, also the side effects that can come from treatment. We have management guides there for you. And then we've just added a new section on clinical trials. We've had an awful lot of questions about clinical trials. What are they? Should I be asking about one? What do they attempt to do? And so we have a brand new section on clinical trials that I invite you to visit. In addition to that, we have Melanoma 101 videos. Not all of us learn by reading, and so we have put together some of this information in the form of videos for you to read. We have a medical expert. Her name is Melissa Wilson. She's a PA. She's a oncology nurse, and her job is not to supplant your care, but rather to make sure that you understand the recommendations of your care team. So you may go to our Ask a Medical Expert page and write out your questions for her. In fact, I hope that we're going to be able to get to most of the questions that came in today, but there have been a lot of questions, which is wonderful. And so if your question is not answered today, I'm sure that Melissa would be glad for you to write to her, and she'll do her best to get the correct answer to you. We have that program has been so successful that Melissa suggested to us that she make webinars based upon some of the most frequently asked questions. So that is what From the Clinic to the Living Room are those questions that most frequently come to Melissa, and I invite you to watch those. You know that you are at a Living with Melanoma symposium. We co-host 10 a year. What we do with symposiums and what we'll do today is immediately following this symposium in its entirety will be available on YouTube on our live page, Aim at Melanoma's live page, for a week. And then following that, we will take each presentation, edit it, and put it back on the same page that you registered for this symposium so that you can watch individual presentations if you need to again and again. And somebody asked me if they can share them with their family, and I ask you to do that. Please do that. We also have a podcast, believe it or not. We're very modern. It's called Beyond the Clinic. Our podcast is about the many psychosocial ways that being diagnosed with melanoma impacts your life. How do you make friends with the sun again? How do you build a support community? How do you talk to your family and friends about your diagnosis? Things like that. And so Dr. Ray Liu, who's with Kaiser Permanente, is our host. He's a fabulous host. I invite you to listen to some of those. They're absolutely wonderful. The last thing that I want to talk about today is our Peer Connect program. It's a one-on-one mentorship program. We have volunteers from all across the country who have been through a treatment journey. They're on the other side of that, but they certainly understand where you are when you are newly diagnosed, how it feels, even when you're surrounded with lots of people who love you and support you. It can be a very isolating experience, and so they're there to lend an empathetic ear and to be a new friend. You can add them to your circle of trust. So with that, I'm going to move to the last slide, which is, this was a lot of information, and we have a great big site, and I am your navigator. So please take my name or come and see me. I've put a card inside your welcome packet. For those of you who are online, here is my contact information. Let me navigate the site for you and get the information for you that you need. And lastly, we put a survey inside the packet that is here for those who've come to visit us today. Will you fill that out so that we can make future symposiums better and better? And if you are online, you will get that survey that will be sent to you as soon as this symposium is over. And with that, I'm handing the baton back to Dr. Switzer, and we're going to get all those questions answered. Thank you.
Can you guys hear me? I'll start the first question. It's a very good question. Please describe BRAF mutation. Yeah.
Thank you very much.
Gonna move here.
Sure.
Well, I think it's the room is small enough so we can hear each other. So BRAF, we discussed a lot about it. It's very famous in melanoma. It's a molecule inside the cell. And normally what it does when it's told to do so, makes the cell proliferate. So it's activated by another stimulus and transmits a signal to the nucleus and tells the cell to proliferate. Normally, it only does that when it's activated. However, the mutation that we talked about changes the structure of the molecule and makes it activated all the time. So it tells the cell to proliferate all the time, and that's what creates growth of tumors. And now, the other question related was what % of patients have this BRAF mutation in melanoma? So, I mean, that's a bit more complicated question. It depends a lot on the clinical characteristic, where the patient population is from, the type of melanoma. Overall, about 40–50% of melanomas will have that mutation, but it's more common in the superficial spreading melanomas, the ones that we discussed are on the back and arms. It's relatively rare in lentigo maligna, acral melanomas, mucosal melanomas, and so on. So it depends a lot on the melanoma. And also, the question that it followed is, how is it treated with drugs and immunotherapy? I think I'll defer on this to Dr. Puzanov, who's going to answer this in more details.
So thank you so much. I talked about the role of the BRAF target in melanoma. It is definitely second to immunotherapy in stage 4 patients. It plays a role in brain metastases, which would be too big, too symptomatic for immunotherapy right away. It may also help, for a short period of time to make some of the tumors smaller before you switch patient to immunotherapy. That was the second bit trial. And last but not least, for adjuvant therapy, after tumor was removed, let's say 3A patients, the ones which have a good prognosis, and they have BRAF mutation, the choice is between nothing immunotherapy and a BRAF targeted therapy. That could actually be a good choice, right there. So they have role, but the role is limited. They, of course, can salvage the patient, after progression on immunotherapy. And so that actually answered another question. What might be the pros and cons of the pill form of immunotherapy? No, actually it didn't. That's a question about pill form of immunotherapy. Well, pill form of immunotherapy, if you can get the CTLA-4 or LAG-3 or PD-1 immunotherapy in a pill, that could make it more convenient. On the other hand, is it worth spending too much time developing pill form of immunotherapy if we already have a form which can be widely used? I actually, to be completely honest with you, as somebody who likes to develop new drugs for people, if somebody came to me and said, Dr. Puzanov, I would like to run trial where half of the patients will get, pembrolizumab, IV immunotherapy, and half will get a similar drug in pill, I would actually say no to it, because I would not want to waste resources on that endeavor. because, at the end of the day, you are looking for something which will be working the same. It will not save more people, and it will be a pill form. That's my opinion on pill form immunotherapy. And I don't know if Dr. Switzer now wants to answer some questions. We kind of divided and conquered to keep it interesting.
You want to go next, you're welcome to. We'll have Joe come up next.
And Dr. Skitsky.
Okay, so I got some really good questions. First question, will you explain recurrence? If the primary tumor and sentinel node are removed, how does melanoma spread? That's a great question because the primary site's gone. If it's spread to the node, that's technically gone. The problem is that we don't know if there's other little seeds that are floating around. And so if you have a positive sentinel lymph node, that's usually a marker of the risk. It's not necessarily the cause of the risk. And so it's possible that little seeds are floating around the system. And so the thicker the melanoma, if it's ulcerated or if you have extensive nodal disease, there is a better or a higher chance that there's little seeds floating around. You may not see them for a few years. And so recurrences usually take, on average, if it's not going to be something rapid, you'll see most of the recurrences within 2 or 3 years after the melanoma is treated. And so that's why we actually do very close surveillance those first 2 or 3 years to make sure that we're not missing anything. But that's a good question. The next question, there are apps out there that offer to diagnose skin cancer. Do you have any confidence in this technology? This is a great question. Actually, Dr. Prague has an interest in this as well. There are some apps that, based on the features and now with artificial intelligence and algorithms that kind of suggest that this, a lesion is melanoma or not. But no, you still need tissue. And so tissue still needs to be evaluated by the pathologist because no one's going to treat just based off of imaging. Imaging may give you some opinion about should it be biopsied or not, and that's a completely different role in the future. The other thing I should mention is that when I said about getting tissue, the next, I think, big thing will be DNA. And so there's groups that are looking at Scotch tape. So you put Scotch tape on a lesion and you remove the Scotch tape, and that brings DNA and some cells with it. And you can test it to see if it's actually, has some of the mutations that we look for in melanoma. But that's the future. Those are in clinical trials. Those are not standard of care. It really requires tissue and review by a good dermatopathologist. The next question, and this is related to intense UV exposures, and it says, I'm a military retiree. Through the course of my Navy career, I deployed to sites in the Indian Ocean and Middle East. Subsequently, many years later, I have been diagnosed with and treated for a variety of skin cancers. I am curious to know if there has been a significant number and type of various skin cancers detected, diagnosed, and treated in the vast numbers of U.S. military personnel who have been deployed in the Mideast since, say, 1990. What sort of data are there skin cancers that have been developed and reported between the Department of Defense and our healthcare systems? So this is an awesome question because yes, there is. There's actually data now showing that the soldiers that were part of Desert Shield, Desert Storm have higher risk of melanoma. Those that were exposed in most recently Afghanistan and Iraq, it's definitely a concern because the melanomas develop decades later. And so we're seeing the tail end of all of it. And there is some data showing that those soldiers are at higher risk. And so the Department of Defense, to their credit, there's roughly $1 trillion budget for the Department of Defense every single year. And Congress has oversight over that so that they have a congressionally directed medical research program that allots certain portions of that budget towards research that would benefit the soldiers and their families. And so melanoma actually in the last few years has been a topic of the congressionally directed research medical program. And so yes, they are acutely aware of it. And then yes, there are actually funding that's going into that. So that's a great question. And then the last question, and this is a good one. Why isn't neoadjuvant treatment the standard of care? Is there any reason to get surgery first? And so it really is right now still like a numbers game. And so and it's really risk and benefit. And so if you have a very early melanoma lesion, surgery takes care of it, very low risk, you're not exposing yourself to immunotherapy that could have side effects, as Dr. Switzer mentioned. And those side effects can be profound and lifelong. So it really is a risk benefit. If the risk outweighs, the benefit of a surgery, surgery is still the standard of care option. I would say that neoadjuvant is becoming more prevalent and people are pushing for it earlier for example, stage 2B and 2C patients. But we're not there yet. And so if there were no side effects to immunotherapy, yes, everyone should get neoadjuvant, but we're not there yet. And so it's really kind of the risk-benefit assessment. And some of that is patient-specific, some of it's treatment-specific, but yes, that's a great question.
All right, a couple more good questions coming through. We won't be able to get through all of the questions, but certainly quite a lot have been answered since I received them. So hopefully some of them that you have written, if you don't hear them be discussed, were covered well. So one question for systemic therapy is when we discussed the Opdualag, which is the nivolumab relatlimab combination in more advanced melanomas. They're asking, are the side effects better with relatlimab over ipilimumab? And the patient specifically shared that they do have a history of adrenal insufficiency on ipi-nivo in the past. And so a couple of thoughts with this. One is when we discussed the side effects previously with immunotherapies, we have the different gradings. So, you have grade 0, 1, 2, which is considered kind of minor, and then we call it serious if it's grade 3 and above. When it comes to the question specifically saying relatlimab, Opdualag is the brand name, is actually, it's a combination of drugs in the same bag. So it's nivolumab and relatlimab in this, and it's always given in a combination every 4 weeks. So it's unlike ipi-nivo, that's 4 doses of combination and then 1 dose, and then you go into maintenance with just nivo. The Opdualag is a combination of drugs continuously for as long as you're on it. And in terms of this specific question of endocrinopathies, as in dysfunction of your hormone secreting glands for something like adrenal insufficiency, the major New England journal for Opdualag, the relatlimab combination, had relatively similar endocrinopathy rates. So it was about 20%, 18%, meaning that the risk is still there. Although overall, in general, we are appreciating that the risk of high risk, high grade 3 or above side effects from the combination nivo-rela seems to be better than the standard dose of ipi and nivo together. So hopefully that helps with that one. How are CT scans, MRIs, and PET scans utilized in melanoma patients, and when would each be used, and what does each show? So this is a great question, and it could definitely take some time for me to go through each of them. They all do have very specific purposes. Some of them need to be utilized because patient intolerance, allergies, organ function, but in general, there are certain procedures that do have more of a gold standard. So for instance, the sentinel lymph node procedures that were discussed by our surgical colleagues, that has a very specific type of imaging modality that needs to be utilized that I did not know can set off alarms, but thank you for letting me know about that so I can warn folks too. Basically, the CT scans are something that are well ingrained within our surveillance protocols. These are well established to be able to monitor tissue changes over time or looking for evidence of recurrence. PET scans are certainly helpful, especially early on in your diagnosis, to assess your true burden of disease, or if we're trying to identify sites of disease that may not have been diagnosed with the naked eye, and looking for any evidence of active malignancy internally as well early on in diagnosis. There are ongoing studies called the Safe Stop trial, where they're utilizing PET imaging to also try and evaluate response of your immunotherapy, but those are not fully played out in terms of the data yet. And then MRIs are certainly helpful with the brain scans. Those are kind of gold standard to really appreciate any evidence of new disease or looking for any evidence of disease within the brain. So hopefully that answered that one adequately. Basal cell and squamous cell carcinomas, if left untreated, could they turn into melanoma? So going back into the slides that we showed earlier of the pathology, of looking at the tissue of the skin, there are different types of cells, and different types of cells can certainly get DNA damage from UV radiation and increase the risk of developing cancer of those specific cells. So the basal cells and the squamous cells are considered carcinomas, which are different cell types than a melanomas. But in general, as we discussed, chronic UV exposure, increasing age, and the other risk factors that were involved those all have risk factors of developing these cancers. And so certainly if one is diagnosed, being established with a dermatologist will be critical, because that will be a way to make sure that you have early detection of any of the others that may come up. Any data to show correlation between COVID shots and melanoma? Also, will COVID shots affect effectiveness of treatment? So I'm not sure who wrote the question. You're welcome to talk with me after. I won't go into too much detail right now, but I do encourage you to Google search, and I don't say that often, Dr. Puzanov and my name and the word COVID, and you should get an article that we published a little over a year ago on this exact topic. And basically, we are seeing that there is no clearly negative impact of the COVID infection or the COVID vaccine when it comes to the efficacy of immunotherapy. We do encourage all of our patients who are actively on therapy or actively getting scans, especially PET scans, if you're going to get a vaccine, please let your medical oncologist know, because especially with the COVID vaccines, shortly after you typically can get an immune response within your axillary lymph nodes that can be very bright on a PET scan, and certainly make your medical oncologist concerned before we realized how many folks were getting vaccines at the same time. So always something to consider there. And I have a few more, but I'm gonna keep passing the torch back and forth with Dr. Puzanov as well.
So I'll be brief. I read about study in mice that said vitamin C supplementation caused melanoma cell proliferation. I actually Googled it. Does this hold true in humans? I wouldn't say any of that was studied properly, and I would not encourage people to take high-dose vitamin C like some patients do. Being on a multivitamin is actually a smart idea. And any question about supplementation, the best you can do is to go online, go to the National Institute of Health, and they actually have an Institute for Alternative and Complementary Therapies, CAMS, and you can ask those questions to those guys because they actually study them. For example, they asked the question, is ginkgo good for your memory? And when they studied, half of the patients got ginkgo, half got nothing, and the memory was same bad. So the ginkgo was not good. While actually echinacea for cold shortened the symptoms by 24 hours. So if you have a cold and you want to take echinacea, it's a good idea. And so I would encourage you to ask them, but again, do not stay away from vitamin C, because if you stay away from vitamin C, period, you will get scurvy like the old sailors. And that is not a fun disease to have. If you read a pirate literature, like I like to do, that was not good. And that was remedied by what? It was actually remedied by bringing a good old sauerkraut on board. And sauerkraut actually cured scurvy. And when the officers wanted the rank and file eat sauerkraut, they actually didn't want to eat it. So the officers started serving it in the officers' mess hall, and then the rank and file sailors were like, "Oh my God, it's a high-end food. I want that too." And that's how they got them to eat sauerkraut, or maybe it was the gin they served in the British Army. But it's really important, please, always ask about these supplements the right people. That's where I go, actually. And when you ask me, I would ask that question. And they are really good because they study it in real detail. If age dampens our immune system, what can we do, if anything, to boost it as a precaution against cancer? So exercise. If you think about it, every study about cancer prevention, women with breast cancer, they got breast cancer cured, and now what they do to prevent it, the ones who exercise live longer. Don't be like, I wouldn't say overweight, little punch is actually apparently good, but don't be like obese. I always ask me a question when I see somebody, 350, and I'm like, what were you thinking when you were like 250? There is I would say, everything in moderation. And it's important, to pay attention to mental health, kind of mind, body, kind of a, really healthy mind, healthy body, kind of a proportion and a exercise. If anything you want to do every day to do in your life, do exercise. It can be simple, it can be sophisticated, but every day if you move for 30 minutes, 1 hour, do some muscle strength, it will come handy when we get old. You will be more spry, you will get better bones, you will be less prone to fall, break your hip. Because if cancer doesn't get us, something else will get us. It's good for, prevention of coronary artery disease. And for stage 4 melanoma, I was taking Ipi/Nivo. I still have residual brain metastasis. That happens a lot, and the question always is it a real brain metastasis or is it just like a scar, on a scan? We watch that, long term, and if it starts growing, we can do pinpointed radiation. Of course, we would like to have better drugs to go into brain. Probably the best center for like brain-specific targeted drug development is at MD Anderson. My good friend, Dr. Hussein Tobi, the one we co-wrote that New England article on Ipi/Nivo. He has a center, he's really studying it. But to be honest with you, it is a slow, hard slog, so radiation is quick, and Dr. Prasad here is excellent, and that's what I do for my patients. If there is a recurrence in the brain, but everywhere else is good, we go and we just radiate it. And sometimes you have to do it a couple times, over the years, and then they stop coming, like you just basically got all the seeds eventually. Which I come to last question, when I say I'm cancer-free. Well, if you have an early stage, like that 1, 2, 3, you got your surgery, all visible cancer removed, whether you got your adjuvant therapy or not, and it's like gone for 5 years, then we go after 10 years, we say, well, after 10 years, you don't have recurrence, we discharge you from our clinic and refer you to the survivorship clinic like Dr. Reed or just simply to primary doctor. For stage 4, it's a little bit more tricky because you never know. I actually always encourage patients to think about cancer in a different way, kind of live in a moment and say, the scan was good, I feel good, no evidence, and that's good. Don't try to go for like that, I am cancer-free, I can ring the bell, and, because I believe, that there is something like hubris and an evil eye. And if you kind of like start jumping too much, I'm good, well, that will turn to you and say, really? And then something bad happens to you. So I encourage my patients to enjoy it, but don't brag about it too much. Just like, I'm doing fine, but not really start loudly announcing, I'm doing so well, because then bad things may happen, So I would say you can kind of say, I'm good, I'm 5 years out, I'm 10 years out, but it's competing, risks, because we are not going to leave this world alive. So I always tell patients, you have to think about others. If you are cancer-free, no visible cancer, you have to start thinking about coronary artery disease, exercise, blood pressure, cholesterol, all these things, joint health, prevention of other cancers, because they may come in sequence. We all know people with multiple cancers. You have to start thinking kind of broadly about your health and how you live. And if there is one message, to leave this audience with, I would say exercise. Anytime you look, exercise never has any really down elements unless you overdo it. But if you are like exercising like a normal person, it's always just benefit, whether you look at anything, any measurement of health. Exercise actually leaves you better.
All right, and I would touch just a few more thoughts on that question too, very briefly. One is in terms of how can I optimize my immune health. Your gut health appears to be a reflection of your immune health, and there's great data that's coming out more and more with that. So, a balanced diet, Mediterranean diet, high fiber diet have been shown to be beneficial there. And then another thing is just if you are ever going to be prescribed antibiotics from somebody in the community that's not us, please call us and let us know so we can discuss it as well, because the antibiotics can wipe out all of your good bacteria, which can always be a negative reflection of your immune health. And then stress reduction as well. It kind of goes along with the exercise, but we are doing clinical trials here actually where we are providing propranolol, which is a reducer of your fight or flight response of your sympathetic nervous system with immunotherapy to see if that can help improve outcomes. And so we do think that there is good science behind that, and obviously encourage you all to practice reducing your stress levels. And we hope that all of the resources provided today can help achieve that. And another comment about all the wig options that were discussed. This was just introducing you to all of the resources. We do not think we're going to cause all of you to lose your hair. That is more of a chemotherapy-related thing that we do not see often. But just so don't think that we were trying to gear that directly to any of you. So with that, I wanted to congratulate AIM at Melanoma for being on their 20-year anniversary this year. That's fantastic, and we're very happy to get to collaborate with them for the first time since 2018, and we hope to keep doing this again. I hope all of this was useful to you and really do appreciate you joining us. The speakers, we really appreciate you taking the time and obviously for the patients and loved ones as well. I will stay back if anyone does have questions that were not answered, so I'll be available here for anybody, and thank you again for joining us.
I do not like to have the last word, but I forgot to say, as I was exiting the podium, thank you so much to Roswell Park for your work every day, everything that you're doing to fight for a future day when there is no melanoma. And thank you for coming and visiting us today, and have a wonderful weekend. Bye-bye.